request Dr. Panja, my teacher, to bless us and give us little short idea about today's program and his well wishes to us.
First, convey my vijaya to everyone who is present here. Today is a fantastic program, the first time done in India, on concentrating on the this drug-coated balloon or drug-eluting balloon. This is a very important issue. You know, after behavioral stent, you see, actually after plain balloon restenosis 30% by 6 months, with grunging done by the 1,000 cases, and followed by the bare metal stent, that is 15% by 6 months, and drug-eluting that is the particularly drug-eluting stent restenosis 3 to 4% by 1 year. So in the meantime, there is enough development of the biodegradable polymers and polymerless stent, as well as the scaffold, which is about 100 micronom available in evolution. In spite of that, so many limitations. So from the 2010 drug-coated balloon, enough work done until now. So the whole world running after the drug-coated balloon. Why it is? Because in case of CABG, so many limitations. You see, after the drug-coated stent, we cannot do the very difficult for the CABG. Number one. Second, in drug, that is a drug-eluting stent. So stent thrombosis, restenosis rate is very higher because of the vascular inflammations, as well as because of the so many complications, stent thrombosis and this restenosis. This is the new atherosclerosis. This is the major problem. And to overcome, again, not only that, you have to continue the prolonged DAPD. That is also disadvantage of drug-eluting stent. Therefore, there is enough work done to overcome all the complication of the drug-eluting stent. So drug-coated balloon, drug-eluting balloon, that is a very important issue. Just all the complications can be overcome by this thing. So therefore, we are happy to announce to start this today's session, and we describe everything, the advantage in issue. The drug-coated balloon, the FDA approved already, is working from 2010. So FDA already approved it, and in the case of the restenosis, stent restenosis, and size branch treatment as small vessel, there is no controversy at all. Apart from that, so many work is going on for erectile dysfunction, peripheral vessels, acute coronary syndrome, so many work is going on. With a few words, I conclude to say, please start the session. Thank you very much, Dilip, to organize the meeting.
Thank you, sir. Thank you. Thank you so much. So we, with this, we start our.
Here, so let in the first speaker in this session, that is the limitation of stent, would be delivered by none other than Dr. Dilip Kumar, known to everybody. So I can request Dr. Kumar to start the procedure.
Thank you, sir. So, we are all in excitement, and we are really intrigued and kind of overwhelmed with the response of DEBs in Western literature, and that is what I am going to give a glimpse. And then we have a whole lot of scientific agenda, which like ensures that we all will be, after 3 hours, will be much wiser in this subject. So metal-free PCI is the need of the hour, as we all have been doing stenting for last 15-20 years, and we have seen the limitations of stents, and we have seen acute thrombosis, late stent thrombosis. We have seen the patients complaining of having other problems because diffuse disease vessel, where entire vessel was stented, metal jacket was done, and then you don't have a vessel to operate on when you are grafting these patients. And these are not very minuscule, 2% increase in event rates per year after 1 year post PCI with all metallic stents across the platforms. And this is the revolution, drug-eluting balloon. So there are a lot of things. It looks like a crystalline. It can be going and creating some toxicity in the myocardium. How these drugs are delivered, how these are being uptaken by the tissue, endothelial tissue, media, adventitia, till what extent it goes in, and then how it responds. Then we'll be having discussion on that. And this is the difference between drug-eluting stents and drug-coated balloons. DES, it is more controlled. DCB, it is more acute and very quick. And then we have a whole lot of evidence with us. And this was the game changer, this meta-analysis, where in ISR, what we got the results with DCB was that the curves were diverging and diverging. With each passing year, the DCB arm was, performing better than drug-eluting stents. And that was how drug-coated balloon was given class 1 indication. And when we look for a search for drug-coated balloons, literature, you see how the jump has happened from 2014 to 15. And you can appreciate 2022-23, you can huge number of studies and data are there online, and these are ever increasing, and the enthusiasm is yet to reach its peak. We had a IVUS nurse workshop yesterday, and this is quite a important finding when we do drug-coated balloons. So we have no metal, there is an intact vasomotion, and also the patient has a kind of plaque sealing effect with drug-coated balloons. So if you perform drug-coated balloons, after 9 to 10 months, the same plaque gives a lesser lipid value when we do imaging. So this is also an additional benefit, what you call cherry on cake, which happens with DCBs, which were not known. So plaque sealing is extra advantage which we get with DCBs, and this is how we see DCBs giving benefits beyond what is assumed. So besides the bifurcation, small vessel, ISRs, we have now studies in calcified lesions. Now CTO de novo registry is happening, and it is going into full-fledged de novo investigation of DCBs. And these are the landmark trials which are ongoing, which will going to change the guidelines, probably reverse, transform to score. And these are all 1,500 to 3,000 odd patients, solution SR. So these are all large randomized controlled trials which are being ongoing, and the results will be coming in next 3-4 years, and they will be the game changer. Then we'll have some evidence, direct RCD evidence that these really work, and they may be finally in with guidelines. This was a story of a UK center where they started doing drug-coated balloon, and see how the DCBs took over the drug-coated balloon treatment. So 2014-15, they changed 90% to DCB. How it changed, and that remained like that. So DCBs versus DES, 90% DCB and then 10% DES. And then in the result, what they showed was in UK registry, the TLR and MACE was lesser than the national standard. So this is also one of the findings where the excitement meets the expectation as well. So I will be leaving with small just introduction about Indian company giving solutions like scaffold as well as drug-coated balloon. So this is a time when we have to move on from tests to scaffolds to metal-free PCIs, and the MIRAS is there. This is sirolimus eluting BRS, and this is 100 micrometer thick, and we all are aware, so I will not go in detail. And Mosaic SCB, that is also a sirolimus coated balloon, and that has a solid lipid nanoparticle which ensures that this drug is being taken into intima and media as always adventitia. This is nanotech delivery for sirolimus in mosaic sirolimus balloon, and this is a time to not looking at a kind of straightway stenting, but lesion specific treatment. So one patient may have a DES, may have a DCB, and may have a BRS. So in future, the patients will have a artery which will be free of jacket, metallic jacket. You can revascularize, you can again do, a drug-coated balloon, you can again put a stent and, give better results in future. Finally, 1 out of 5 patients at this time in Japan, they are getting DCBs. So the enthusiasm is taken into practice as well in Japan, where 20% of the angioplasties are being done with drug-coated balloons. And I stop with this slide. Those who were seen dancing, were thought to be insane by those who could not hear the music. So let's dance because we hear the music of drug-coated balloons, what it is going to create in future. Thank you so much for the patient hearing.
Late. Everybody are now going to start. FDA also approved in the US also. And in the last the PCR meeting, and the 50% of at least 30 to 40% talk on the DCB. Every country running after DCB. I think there is a near future coming. So in our country, in compared to the state, the DCB little higher cost. I request all the company, it is reasonable cost, so they can use aggressively for benefit of the patient. Thank you, Dilip. For any question from the floor? Yeah, Dr. Sharma, please.
So DCB, when the journey started, it was DCB. So Dr. P.C. Mandal will tell us something like that. But now elution is also not a wrong term, because now the technologies are there which elutes the drug slowly over 40 days, 60 days, 90 days. So we can use now both DEBs and DCBs depending on which balloon we are using. So some balloons are DCB, some are now DEB as well.
So may I request one?
No, from idealistic situation, it is DCB, drug-coated, because the drug will be given to your intima, and that will be the storage now. That means from balloon surface to your vessel surface, and that will be the reservoir, and that will percolate to your smooth muscles, subendothelial matrix. That means from there it will go in. That will be a different force. I will tell that. So it is a drug-coated balloon.
Sure. So one issue actually what vessel size in Indian scenario do you recommend for it? Actually in the Indian scenario, what the size of the artery size would you recommend up to for diagnostic balloon?
So ISR, it's already class 1 indication. Size of the vessel doesn't matter. But small vessels which are considered less than 2.75 in drug-coated balloons, and we have got very good results with basket small trial, other trials as well. And bifurcations where the side branches are being treated with drug-coated balloon after a cutting balloon, and then main vessel angioplasty can be done. So if we are talking about small vessel angioplasty with DCB, it's less than 2.75, sir. Less than 2.75.
Small vessel, my definition is 3 or less.
2.75.
So starting from 3, they define the months. Very extensive use, particularly commonly used on the particular distal LED is very usual use for the DCB. Doctor, now the next, any question?
No, yes, you can start your next. Next speaker is Dr. P.C. Mandal. What is the choice of pharmacology? It is paclitaxel or sirolimus. He will be talking on the paclitaxel. You please.
So DCB pharmacology, that means that we are going, not moving. So what are the elements of drug-coated balloon system? This is a balloon that is a standard wrapped configuration balloon. It's a semi-compliant balloon and is a wrapped configuration. That means it will not be collapsed like that, it will be a wrap. That means it will be folded, suppose 8 or 10 folds, that will be wrapped. Like your umbrella, when you are making it small, it is a wrap. It is a wrap-like balloon. So surface modified to adapt to that thing. That is the change in balloon system. Then anti-proliferative drug will be there. It will be impregnated or sprayed. That spray can be of different methods, I will tell that. And regarding drug of choice, all are mostly anti-cancer drug. That means anti-mitotic drug, anti-proliferative drug, paclitaxels and limas family, and some other drugs are also in the pipeline. But till now the paclitaxel is the agent of choice till now. And excipients, that means most of the drugs are lipophilic and they are not well dissolved, solubility is very poor. So that to be carried by another agent, that is the excipients. And excipients used initially was ipromide, urea, some of the polymers and some nanoparticles. Dilip has already told about a balloon with the nanoparticles. And the concentration of the drug in the vascular wall is the fundamental factor affecting the therapeutic effect. That means you have to carry the drug to the vessel wall. Now your reservoir of the drug will be the vessel wall. And to improve the efficiency of drug administration and effectively inhibit the intramural hyperplasia, attention should be given to the lipophilicity of the drug. More lipophilic drug will be more valuable, but that to be carried. Second is administration time. That is minimization of drug loss in the process of transporting drugs to the designated sites. You should be very fast from beginning to end, from your femoral site or radial site to reach the site. Otherwise you will lose most of the drugs. And PPR well and trackability will be an issue. You should not lose too much time to place the balloon there. Otherwise the result will be suboptimal. And strengthening of the bonding ability of the drugs. That means drug to be bonded to the vessel wall. That is another prerequisites. So these are the components given in another picture. Balloon, and there is some carrying agent and drug. And lipophilic character is one of the basic thing that is needed. And influence of the type, dose and chemical properties of the coating drug on drug-coated balloon, and that's a very critical issue, otherwise the chance of delivery of the drug will be very poor. And usual concentration of the drug is between 2 to 3.5. Why so much of difference? Because particularly paclitaxel has a peculiarity that its uptake does not obey concentration gradient. That means it is mostly bond related issue that will bind the drug to the vessel wall. It is not the actual concentration that will determine. And uniformity of this drug coating is another issue. Last line, paclitaxel uptake does not obey concentration gradient in characteristic contrast to hydrophilic drugs. That is the peculiarity that make it one of the drug of choice till now. And paclitaxel inhibits cell proliferation by promoting the formation of microtubules and inhibiting the decomposition of the microtubule during mitosis. And that's stopping the cells in G2M phase interface. That means it will cause a programmed apoptosis of that cell. It is a cytotoxic drug. In contrast to all limas, they are cytostatic. And that is the explanation that there will be cell death in next few weeks to months. And that is the cause of positive remodeling. And not all drug-coated balloons are created equal because of this chemical characteristic of the drug. It is a cytotoxic drug that is more able to cause positive remodeling. In carrier, how it is getting carried, and drug excipient ratio, that will determine how much crystallization of the drug will happen, how much drug will be embolized to the distal circulation, and that is more particularly important for long oversized balloon for peripheral use. Peripheral balloon has got bulky, drug content will be too much. So there is a chance of distal embolization. And coating should be uniform. The technology should be in that way that there should be an uniform coating, and wrap up of the balloon should promote that there should not be any unequal distribution. And elution profile, this elution profile has got changed with third generation DEB. Because this elution has got changed to dark coating, that's because of elution is not from balloon now, it is directly from the vessel wall. And clinical data, that is why paclitaxel then highly lipophilic, rapid intercellular uptake and retention in the vessel wall for nearly a week, and acts by irreversible binding to the microtubules, and that cell proliferation will be inhibited and will be ultimately there will be some programmed cell death. That's why this a potentially beneficial aspect of local paclitaxel therapy is positive remodeling, and that is because of its cytotoxicity and programmed cell death in future. And current DCB paclitaxel dosing 2 to 3.5. Most of the balloon contain 3. Why this concentration? Explanation is if there is a specific dose, if there is an overdose, chance of local aneurysm formation, distal embolization, and chance of distal tissue necrosis will be there, and chance of late thrombosis is there. That's why up to now 3 microgram per millimeter square is the dose, and local tissue effect and safety is limited to this dose only. And influence of excipients and coating methods on drug coated balloon, this is another area. This combination of lipophilic drug and hydrophilic excipients will produce a highly crystalline coating, which is unstable. Once in the circulation, will form particles with risk of embolization, that to be minimized. Changing the ratio of drug to excipients and improving the spraying method to maintain the stability of the coating could be the effective method to reduce this bad event. Impregnation, air spraying and ultrasonic spraying. Most of the technology now using ultrasonic spraying, and can be adopted to keep the surface of the DCB smooth to reduce the occurrence of embolization. So impact of drug restenosis on vascular toxicity and efficacy, that is one most important area. And paclitaxel formulation types, that is also very important, crystalline versus amorphous. It should always be crystalline, otherwise vessel adherence will be much less. And tissue transfer and retention is more with crystalline than amorphous. An influence of contact area and pressure between the drug-coated balloon and vascular wall on drug-coated balloon drug delivery. Contact area and micro-indentation pressure between the DCB and vascular wall. What is that micro-indentation pressure? In micro-indentation pressure is, once there is a spray of crystalline thing, the pressure will be from that crystals only, not your balloon wall. So this transfer of this pressure to this vessel wall by this crystal, how they are stable, whether they are tolerating the pressure or not. If they tolerate the pressure, they will be thrown back, they will penetrate the wall. Otherwise, if it is not the pressure of the balloon that is creating everything, that pressure is now transformed into a micro-indentation pressure. And that has got a strong impact on this, because it is positively correlated with this coating adhesion and van der Waals adhesion, that means by contact force, and ionization of the drug and bonding with the vessel wall matrix. And high inflation pressure will cause plaque rupture, aggravate vascular injury, increases the possibility of vascular dissection, even cause negative vascular remodeling. That's why most of the DCB usual pressure is from 6 to 10, not more than that. Very high pressure inflation is avoided. If you have to open up the vessel, you have to open up before taking the DCB. And microneedles are seem to be an emerging innovation in DCB and related to the intervention. That's a upcoming thing. And influence of the surface temperature of the drug-coated balloon on the drug delivery is also important. It should be in room temperature. Otherwise, if you are taking from some cold area, it will create a problem and chance of drug dissipation will be much less. And interfacial mechanism during DCB angioplasty, interfacial mechanism means deflation should not be very rapid also. Because this microindentation, there is a positive bonding. If you are deflating, it should be slow. Inflation can be rapid, but deflation should be slow. Otherwise, there is a balloon deflation will cause some interfacial deformation. And this is microindentation. This is the, I'll skip that. This is the first generation DCB. This is the second generation DCB. Another thing that I have omitted that I should describe, morphology of morphologically intact vessel wall will impede drug penetration. This I will complete with this slide. This different composition of atherosclerotic plaques has discrepant effect on the absorption and retention of drug. That to be kept in mind. Biological response after intimal injury and the intimal pharmacological response to drug all are different with different plaques. This lipid content in the atherosclerotic plaque weakens the effectiveness of lipophilic drug. Dr. Sharma was asking whether it will be very effective in acute MI or not. That will be a debate. Because if your plaque is too much lipid rich and you are giving a lipophilic drug, it will be more towards the lipid core, not to the smooth muscle cells. Distribution will not be even. Second thing, lipid content atherosclerotic weakens the effectiveness, and extracellular matrix play a key role in distribution and retention. Vascular beds with more elastin have greater absorption and deposition capacity. Lipophilic drug preferentially bind to elastin and tend to be distributed in deeper layers of the arterial wall. And calcium ion can affect the structure of the elastin, that's affect drug absorption. Calcium is one of the hindrance to your, if you want to modify that calcium, do it fast and then do DCB. Morphologically intact vessel wall impede drug penetration, while moderate plaque and vessel wall damage, that means you are creating micro dissections, can facilitate antiproliferative drug delivery as well as tissue retention. These are the important, that's why it is very important that you should prepare the vessel beforehand. Otherwise, the chance of drug delivery to that site will be much less. Still now, the paclitaxel remains the gold standard drug. Though other drugs are on the way, it will take around 5 to 6 years more to come up with the long RCTs, whether limas is better or paclitaxel is better. Till now, as an antiproliferative agent, paclitaxel is much better because it is cytotoxic. It has got some positive remodeling effect. It is long lasting and tested more than limas. And with this, I am completing here. Thank you.
Thank you. Another thing, particularly in case of sirolimus, anti-proliferative effect, anti-inflammatory effect stronger than the paclitaxel. That is another disadvantage of that thing. But overall, until now, from 2010 to 2022, so galaxy of articles published, and B. Brown was the first they published, and second Medtronic, and the Boston's, and all the companies come out with particularly paclitaxel, and therefore it is already proved, FDA approved, so many advantage because of that. But thanks to the newer molecule also coming, you have yet to establish which is superior, whether sirolimus versus paclitaxel, yet to prove later on. Any question from the floor, please?
Just, I am adding one comment with that. This, just an addition, that's something came to my mind, that if the vessel size is less than 2 or 2.5, better to use paclitaxel, so that positive remodeling will be well tolerated. Suppose the vessel is having some ectasia, we are using 3+, then maybe paclitaxel may be a second choice. That will be proved in time because the positive remodeling creates some bad thing in that area. From that point, it is some of the trials are ongoing, so we cannot comment on that. But as a comparative thing, the limas versus paclitaxels, still now in the future also in small vessels, paclitaxel will be the choice.
Sir, because
Yes.
it causes positive remodeling, paclitaxel. That's why it's being more kind of people are trying to use this in more small vessel and all. So you told, but the exact mechanism of this positive remodeling, initially it was thought that it reaches to adventitia as compared to other sirolimus coated balloons. Vessel can become little more ectatic, larger, and second is there is a distal embolization of crystalline materials. So these crystalline particles, in some of the studies they have shown that they cause necrosis of particular myocardial segment. So how significant is this, and which balloon has got how much embolizes? Is there any percentage like 15%, 20% of drug which we quote there? How much is the percentage which distally embolizes?
No, if you see in most of the drugs, if you suppose you take 100% as your coronary entry point, you will lose around more or less 50% of the drugs. After reaching that site, you will lose more than another 30 to 40% as a distal embolization. Only 1 to 10% of the total drug what is in your balloon will reach to the vessel wall only. It is very less. Very less. And regarding embolization, it was the first generation balloon, the problem of distal embolization was with the first generation balloon, more with peripheral balloon. For coronary balloon, for second generation, third generation balloon, embolization is negligible. And regarding positive remodeling, it is not the tissue necrosis, it is just a programmed cell death, it is also a apoptosis, not necrosis. Necrosis is an inflammatory thing. What is the difference between necrosis and apoptosis? Necrosis is an inflammatory cell death, and apoptosis is a non-inflammatory cell death. It will die, but it will not cause surrounding inflammation. If there is a surrounding inflammation, there is a chance of fibrosis and restenosis. That's why it is an apoptosis, programmed cell death. I have to bring that slide. If you can project it again, and I have bring that slide here. So please give the projection. It will be clear for everyone that this positive remodeling will be a backdoor. It will be a problem for paclitaxel itself in future. If you going to use in a big vessel, chance of positive remodeling will create problem in future maybe. That's why for small vessels it may be a choice for all time. But limas will take entry in that area because positive remodeling will be much less.
Because
It is a cytotoxic, that's a cytostatic.
most of the drug, you have to be concentrated only media. Initially intima, but media concentration very, very important issue for the prevention of
there is
this
a lot of
other
discussion
complications.
on one of the study which just happened, Transform 1, and these paclitaxel balloons, they are saying that they give larger lumen, and this was the only endpoints which was measured there. And but there is no clinical difference at 9 months, 10 months, 11 months. There was no difference in MACE and TLR. So how much is this lumen gain is going to behave clinically beneficial? It's also not known. So at this moment, we can't say that paclitaxel is good or sirolimus is good. There is no class effect of paclitaxel or sirolimus. So it's all kind
That's
of
why I'm telling that what will be the problem in future with paclitaxel, we don't know. That is a assumption that in big vessel it may create problem. Another thing that has been proved with this paclitaxel, that it reduces the activity of the inflammatory proteases. In contradiction, that we can think that there is a tissue damage, it can cause inflammation. No, this reverse thing is true. If you go through the third line, there is a DCB-PA, that is percutaneous endovascular angioplasty, reduce the activity of inflammatory proteases and postpone the progression of the disease. While the anti-inflammatory effect of paclitaxel could shorten the double antiplatelet time. It is a reverse thing. What we are thinking, that's a reverse thing actually.
Dr. Suman Rai, I think you are asking a question.
Swarna, any comment? We are starting
comment
just
from
that
anyone?
This kind of discussion will be at the beginning. Afterwards, it will be case
Actually,
discussion only.
at the present moment, what is going on, considering all the pharmacokinetics and pharmacodynamics, the drugs should be in choice will be in order like paclitaxel, followed by sirolimus, followed by jotarlimus, and followed by biolimus. This is up to date at the present moment status.
The point is, why I use a paclitaxel balloon or whatever balloon, DEB? Because, you see, if you look at the pathology of balloon angioplasty, you can go to the old time reports. This was the earmark study which was published from Japanese group in JAC in the year 1995. They showed that after balloon angioplasty, the inflammation remains in the vascular wall for 1 day. Between 1 to 5 days, there will be some dissection, some inflammation, and after that, the smooth muscle cells will come into the, you know all these, you come into the, to form the neointima, and for within 28 days, the healing is complete. So, if this neointima formation is sometimes more than what is expected, and there is restenosis. This is the basis of pathology of balloon angioplasty. Now, what we are gaining from drug-coated balloons? The drug-coated balloons should prevent this neointimal proliferation and excessive neointimal proliferation, I must say. So how it happens? When you use a drug-coated balloon, after balloon angioplasty, and you know that when there is a balloon angioplasty, it will create some amount of dissection, which may be a controlled dissection, and mostly they go to the media and injure the media, and from there the smooth muscle cells come into the neointima. Now, the importance of balloon drug-coated balloon is the drug should go into the media and around the intimal cells, and that will prevent the neointimal proliferation or foam cell transformation, and that will prevent the restenosis. Now, why paclitaxel is important? The paclitaxel is lipophilic. It goes to the receptors and stays there for at least 30 days, even more, up to 90 days. But sirolimus, because it is a hydrophilic drug, so it can be washed away. It doesn't act like that. That is why sirolimus needs some excipients or something to be put into the vessel wall.
Thank you, sir.
Basically, this is the thing.
So,
last point is about the positive remodeling and everything. So far, the latest randomized trial in big vessel and small vessel, it is disaster in big vessels by DEB. Drug-coated balloons are inferior to drug-eluting stents, so far. So we are talking, till date, we are talking about the small vessels. In the small vessels, whether sirolimus is better or paclitaxel is better, we do not have any consensus nowadays.
Thank you, sir. I think in the interest of time, we have to move. We have 18
last
presentations.
question, that is the
Dr. Kuntal,
Sumaran,
please.
Than limus.
So Dr.
That is
Hazra
the
is waiting
relation.
for his turn. He will tell us
Okay, okay.
about sirolimus and how it is going to behave.
we will talk another
angioplasty with lowest possible statin by multimodality approach with inclisiran, whatever drugs is available, shorter DAPT, and stent-free life for everything. So the biggest advantage for operators are you don't need to measure the length, because most of the time if it is acute situation and we are dealing with a 2.75 millimeter vessel, so maybe a shorter balloon. In case of ISR and longer stent, you need a longer balloon, that's all. So the attractiveness of drug-eluting balloon and the major, I think it is a big game changer. It will be a big game changer, because you know the first generation stent, drug-eluting stent with Texas is no more available, and paclitaxel is the molecule which is only remaining probably in market in cardiology for drug-eluting balloon, both for peripheral angioplasty and coronary angioplasty. This limas is a big basket, starting from sirolimus, zotolimus, everolimus, and everything we are using in large number of stents. So sirolimus is actually a rapamycin. It's a very old molecule. It was actually first discovered in Easter Island by a Canadian team, and it is actually produced from a bacteria Streptomyces hygroscopicus, and it is first detected and used as an antifungal, anti-candidal, and later on when we discovered that it has a very potent anti-tumor and anti-proliferative agent, then all these studies came. So this is the cell cycle. You all know this is the very common picture from Robbins, and it is the pathway of cytostatic versus the cytostatic agent is rapamycin, all rapamycin group and limas group, and the cytotoxic agent, the toxic means it kills the cell. So it is simple, it kills the cell. Whatever it is not equivalent to apoptosis. Apoptosis is completely separate thing. So the first killing is by toxicity. The second phase is probably apoptosis. So I will differ a little bit from Dr. Mandal. And the sirolimus is a cytostatic agent, so it inhibits the proliferation of the cell by blocking the pathway in the S phase. So from G1 to S phase, it prevents that pathway. So if you see, it is a fantastic anti-proliferative agent. It is a cytostatic drug, and there is no anti-apoptotic or cytotoxic activity. It is a low lipophilic or hydrophilic drug. The tissue absorption is very slow, and the tissue retention is also short, and this is the drawback. So you need to design something so that the tissue penetration and tissue retention is more, but the safety margin is very high. So in case of paclitaxel, if you give higher dose, the patient may develop ectasia or aneurysm at that particular segment, and there is also increased vascularities in the distal bed. So the principle of drug attachment is fixed law of diffusion, whereas in case of paclitaxel, it is a van der Waals force of attraction. So now coming to the sirolimus on smooth muscle cell. So it is a very specific action on smooth muscle cell. It inhibits individual smooth muscle cell proliferation. It reduces hyaluronan accumulation, which is actually stimulant for neoantimal hyperplasia, and it is also an anti-inflammatory drug. It reduces monocyte adhesion, inhibiting protein and collagen synthesis, and prevention some amount of lipid accumulation in the atherosclerotic plaque. So these are the different balloon available with sirolimus. We'll talk mainly on Magic Touch, and sequence please. The solution is for peripheral vessel. So this is the product image of Magic Touch. So it is a folded balloon. If you see by a magnification or zoom at 500 times, then this is the surface of the balloon. With 1000 time magnification, you can see the balloon is coarse, and there is multiple drugs with phospholipid attached. So this is a typical nanoleo technology, and it is now approved by the US FDA. So the sirolimus, the main problem is the shorter activity, shorter duration, and it easily washes away. So some carrier is required for retention, and that is the phospholipid. With that phospholipid core, when we inflate the balloon, it then diffuses inside the intima, then it comes into the subintima, then it goes beyond the subintima into the smooth muscle cell. And that is there, it is getting retained, and over a period of time, it gives its effect. So initially the balloon is coated, then it is refolded, and when we inflate, then the drug is actually released into the vascular smooth muscles. So the nanoleo technology is a technology which facilitates a better adhesion and effective drug transfer to the vessel wall, and the circumferential coating of the particular balloon is helpful, and it is better in tissue viability for all kind of sirolimus. This is another kind of balloon which is based on crystalline cellulose technology. When the balloon of sequence is inflated, the crystalline sirolimus get dissolved into the subintimal surface, then gradually it imbibe inside the smooth muscle cell. So usually the pressure during inflation is 6 atmosphere. Usually it is a 1:1 vessel diameter. So before that, if patient requires any preparation of that bed, do a 1:1, avoid major dissection. So anything below type C dissection is okay for this balloon. Beyond type C dissection, probably the patient will require stenting, which is a flow limiting. Usually a single inflation of 60 seconds with a gradual deflation, and it is a semi-compliant balloon. So avoid overinflation that may cause edge dissection, and you may land up with stent in that time. The drug's dose for sirolimus is little bit lower in comparison to paclitaxel. It is 1.27 microgram per square millimeter surface. Coming to the cytotoxicity versus cytostaticity. So whenever a paclitaxel balloon is inflated, the initial lumen gale for 30 days, initial 30 days will be much higher than the sirolimus eluting balloon, because it is the cell necrosis immediately happened with paclitaxel. So the initial lumen gale will be higher. In case of magic touch, you can see the initial lumen gale may not be higher because there is no cell necrosis here. But over a period of time, the smooth muscle cell proliferation will be prevented. Now coming to the vasculitis in the distal well, whenever there is a paclitaxel eluting balloon and there is a particle will be diffused and it will be released inside the circulation, it will clog the distal vasculature. So there is definite vasculitis, and this vasculitis may lead to some adverse event in long term. In case of sirolimus, this chance is lesser. But with the newer technology of paclitaxel, even I will say this is also lessened in agent. So this is the Magic Touch Eastbourne real world registry. Here almost 2,400 patients were studied. Almost 2/3 of the patients were ISR and 1/3 of the patients were in de novo group. And you see the result, almost all the vessel size were around 2.75 to 2. The mesh rate is 9.9%, 1 year outcome. The TLR is 5.9%, the MI is 2.4%, and death is 2.5%. So this is the plaque written in Portuguese. It is commemorating the discovery of sirolimus in East Ireland in Rannoch. It is probably in 1961. And with that, I'm ending. Now we can go forward with some discussion.
It is the 30%. And Grunjik in a study more than 1,000 patients published on JACC a long time before. And because of that drug, you see, drug-coated balloon, so restenosis definitely by TLR is the 5 point very significantly low by 1 year.
Yes.
And MACE is also 5.9% significantly lower. There is no doubt at all.
Whereas
That proves that is the drug-coated balloon very, very efficacious compared to plain balloon. And not only that, it is a comparable result with the DSA. There is no doubt at all.
The DS TLR rate is, I think, even higher in the 2-digit. I think
That depends on which type of stent we are using.
Yes.
That is also important. So keep in mind that is only left behind only two things. One is the drug-coated balloon, another is the scaffold, which is now in the 100 micron. You also in the way to prove which will be superior and efficacious, particularly concerned to cost. Any comment from the floor?
So, as a paclitaxel coating balloon, they have got crystalline, structure there. So, do you feel the deliverability of, PES and SES differs?
I don't think, because it depends on if you take a very long balloon and if the artery is very tortuous, then there's maybe some problem during deliverability. Otherwise, I have used both the balloon in the length of 30 plus. I don't think there is significant deliverability problem.
No, there is a point,
balloon. Yeah,
to answer to your questions.
Sirolimus balloon, actually,
we
it is the particularly micro crystal.
Yeah.
Initially,
So sirolimus for magic touch.
The point is, you are talking about the initial balloons when crystalline
First generation.
paclitaxel was being used with iobromide. Nowadays, the microcrystals of paclitaxel has been used with a definite technology like microneedles or something like that, so that the microcrystals does not produce embolization because they are very small. And similarly, the sirolimus are like nanoparticles. They do not produce embolization. So this is one point. Second point is the the deliverability of these balloons are definitely less than the normal balloons. There is no doubt in it, but still they are deliverable. It's not that like opium balloon or something.
Because it is a semi-compliant balloon at all.
Yes, initial paclitaxel coating
Another
balloons were difficult to
And
deliver.
most of the vasculitis, those studies are in peripheral vessels, I think.
another thing in the case of Medica.
The fast generation.
First generation, and it
First
is on
generation,
peripheral
yeah,
vessels.
Peripheral vessels and also in the fast generation
So two sirolimus drug available in the market, commonly used in the
Sir,
world.
even
But one is a
one
1.25 micron in case of sirolimus magic touch. But the solution is 1 microgram. Why so much drug difference? What is the advantage of the two things? Yet to establish, of course.
That may be because of the elution technology. So it is the mechanism in the balloon, but maybe at the tissue level both are same. So this is very difficult to answer, but I am sure because of the elution technology, probably it is the difference.
Prakash?
In third generation paclitaxel eluting balloons, there is no carrier.
Yes,
No
it is only
carrier.
coating.
Only coating. Elutax has got some hydrogel, and this what he has given here also. This Protege has got no carrier. Nothing. Only drug is impregnated by ultrasonic spray. It is on the balloon. Whenever it is with the touch of the vessel wall, by bonding it will go to the vessel wall. And that vessel wall will be the depot for the drug now. There is no carrier, nothing. Third generation balloons are very technically advanced balloon. Only thing that the cytotoxicity of paclitaxel, how much the vessel wall will tolerate, that is the question that is even to be answered till now. Within next few hours, it will be proved that whether this cytotoxicity can be a dangerous thing for long term or not. That answer to be given to paclitaxel eluting balloon. Otherwise, till now the paclitaxel is all right from all sides, because even without crystal, without carrier, it can be given to the vessel wall.
Magic
Thank
says
you, sir.
one
Thank you,
study is going on. The duration inflations, you see, maximum is 60, they are 6 to 8 atmosphere pressure. But one study also, just I got the abstract in the JAC, the duration even 2 minutes inflation is going on.
Thank you, sir. I think
only 60
we have
seconds.
Dr. Kasturi waiting online, and thanks to Dr. Panja and
Okay,
Dr. Samtrugos.
Okay, thank you very much. All this
And-
well discussion
Thanks
and
to
thankful
Dr.
to
Kuntal
all
and
the
Dr. Mandal.
speakers.
So may I invite the chairpersons and moderators for the next session. Dr. Prakash Hajra, Dr. V.P. Pandey, and Dr. Indranil Datta. Dr. Sridhar Kasturi is online, Prakash Da.
Sridhar?
Yeah, okay.
Sir, I'm Dr. Hajra here, and we're waiting for your talk. Along with me, we have Dr. B.P. Pandey and Indranil Datta. Over to you, sir.
Sir, are you able to see my slides?
Not yet. Yeah, now I can see, sir. Now I can see.
Okay.
You're good to go.
Respected chairpersons, good evening to everyone. And really, I'm very thankful to Dr. Dilip for inviting me for this session. So let me share my DCB experience. So what are the established indications? So usually everybody knows very clearly it has an immense role in ISR lesions, side branch lesions, and the small vessel disease. And recently they are also using regularly for de novo lesions, particularly when severely calcified, acute tortuous bends, and sometimes when the stenting is not possible. It has other indications like diabetic patients with long diffuse lesions, where there is a DAPT compliance or a high bleeding risk patients, or even in some case of acute converse syndrome also, it can be applied. So what are the advantages? I will briefly narrate some of the points related to the DCB. More homogeneous drug distribution, no risk of stent thrombosis, no jailing of the side branch ostium, and it has no other stent-related issues like a stent fracture, LSD, malapposition, neoarthrosis, non-endothelial stent struts, abdominal placement of wire, difficulty in placing stents in acute angle and touch with this. So these issues will not be there with the DCB. These are the advantages, particularly when you do the complex case with unstable situation. And short DAP duration also helpful in high bleeding risk patients. There is also some evidence of late luminal gain due to vascular remodeling was observed in 60% of patients. So casing of the vessel will not be there. It restored the normal vasomotion of the vessel. So potential of allowing vessel to function normally, that is no metal casing. And recently, there was a publication of DCB consensus group. So how to do the DCB plastic? So always lesion preparation is very, very important. So DCB should not be used for the preparation of the lesion, and always prepare the lesion. If it is a lipid block or fibrolipid block, use the semi-compliant and NC balloons. Suppose the severe fibrotic block is there, scoring or cutting balloon should be used, and always use the balloon to vessel ratio 1:1. Never exceed more than 1:2. More than 1:2, chance of perforation very high. Suppose if the patient also has a severe calcification, it is also allowed to do the rotablation, lithotripsy, or you can do the orbital atherectomy. And once you do the procedure, if lesion is suboptimal, that means residual stenosis is more than 30%. And if the patient is having FFR more than, is it negative or not? That you have to find. If you are not very certain about the angiographic result, then you can do the FFR, or you can see the intravascular imaging and have you got the very good luminal area or not. That is important. And suboptimal angiographic result, suppose if the patient is having a flow limiting dissection and TIMI grade 2 less than TIMI grade 2 flow, and residual stenosis is more than 30% and FFR value of less than 0.8, in such cases, better to go with the DES. But if you have met the optimal criteria, you can implant the DCB. So pre-dilatation, usually you can 1:1, or at least you can less than 0.5. And scoring is recommended in fibrotic lesions. And do not touch the balloon directly or wipe its surface. Do not inflate the balloon prematurely. No contact of balloon surface with the liquids. These are the important features. And the balloon size should be 1:1 or to 1.1. If you exceed more than 1:2, chance of perforation is very high. And depending upon the device, you can use one inflation, like a Magic Tech standard, say they 2 inflations. The Protege, they say 3 inflations. Sequence, they say single inflation. So usual inflation time, 30 to 60 seconds. And usually I use like a Magic Touch, all balloons like a 1 minute application. And DCB should be distally and proximally. So if you are using the DCB, at least landing zone, beyond landing zone, 2 to 3 mm should be covered. And DAPT, you can maintain only for. So this is the meta-analysis, 4,005 patients, where they compared patients underwent balloon angioplasty, bare metal stent, drug-eluting stent group compared with the DCB. They showed superior results in this meta-analysis. there is a dividal study. This is mainly ISR, nearly 10,000, 10,000, 1,033 patients underwent PCB application, 943 underwent DC application. If you see the target lesion revascularization, 16 versus 12, whereas all-cause death myocardial infarction, target lesion thrombosis 9% versus 10.9. That is, there is no significant. It's a non-inferiority trial. And as of now, DCB based upon the trials, the possible indications are instant restenosis. These are the various trials based upon the Restore, ISR, SEDUCE, PEPCARD. And small vessel trials, mainly basket small 2 trial, Restore SVD. So based upon these trials, the currently it's recommended for these subset of patients. So let me narrate some of the cases. This patient was admitted with chest pain associated with grade 2 SOB, who underwent procedural stenting of left main to LAD, and she stopped DAP therapy for 15 days. So she came to us with anstomy, with hypotension, and troponin I was 186 nanograms. CAG showed distal left main, that is almost 90%, very critical stenosis of the left circumflex. So then, because patient comes under very high risk status, left main very critical stenosis, we put her on IABP support. So we prepared the lesion as per the recommendations, NC and angiosculp. We used angiosculp 3 into 10 mm. So LM and LAD area and L6 areas were dilated optimally with the angiosculp, the lesion preparation. So subsequently, we acquired the OCT image. If you see the OCT, there is significant fibrotic, and these are cuts related to the angiosculp. You can see very clearly. And so then, because LCX was not stented, our intention is to go with the LCX stenting and DCB of left main and LAD to avoid the more metal burden. And now we implanted 2.7.12 mm resolute onyx and Alex DEB into the LAD. This is a sirolimus coated balloon. Now you can see the stenting and a long balloon inflating across the left main to LAD, and subsequently a part was performed. Subsequently, we acquired the OCT to see the results. You see the osteal L6, we got 6.3 square mm, expansion is 122%, and distal edge is almost more than 100% expand, 118% action, and distal landing zone, MLA is about 4.5 square mm, and LD is about 2.4 mm. And post-DEB, proximal LAD, the main stent area, the previously implanted stent, and presently we treated with the DEB, 6 square mm, expansion 113%. And mid-LAD 5.12, which is a very good expansion. So you can see the final result, and resolute annex, you can see the final chart, and then this is the final angiography result. So nicely flowing L6. This patient has been under follow-up for the past 3 years. She is doing extremely well, and we told her to comply with the DAP therapy. So this is the case, 50-year-old female patient, unknown diabetic and hypertensive, present with a chest pain for 2 days, typical angina, ACS evolved anterval MI. You see the angiogram showing the left main with the two-vessel disease. LAD is totally occluded at the origin. Echo showed ejection fraction 38%. And you can see the ECG showing evidence of anterval MI, and left main distal 20 to 30% is an osteal occlusion. And this is the picture. You can see the OCT, entire the LAD showing the fibrotic and proximally fibrolipid plaque with the area of a ruptured plaque. So I'll show the analysis. I'll go to the analysis because of the delay. Now you can see the entire fibrolipid plaque. You can see the very, very thick, distally very fibrotic plaque and proximally fibrolipid plaque. You can see the plaque rupture area. This is the empty cavity. Here the ruptured plaque. This is the white thrombus. A very critical lesion. You can see the cholesterol crystals as well as the macrophages indicative of high risk patients of the plaque. See, then we did the as proximal to mid LAD, 2.7 to 28 mm Science expedition, LMCA to LAD, 3.5 to 23 mm expedition stent. Then part was performed with 4 mm balloon. You see the angiogram, distal LAD diffuse disease. There is additional diagonal, which is also diffusely disease. Then what we thought, because there is a diffuse disease of the LAD, even OCT showed, you can see that distally, it is a thick fibrotic plaque and plaque burden is more. So to produce the long-term benefit, we thought of giving a DEB to the distal vessel. The stent is nicely expanded. If left main, if you see initially, it was about 5 to 6 square mm. Now we got 12 square mm. And everywhere expansion is adequate, more than 90% expansion. And now this is the analysis of the, you can see that distally that the thick fibrotic plaque and areas of lipid and plaque burden is more than 50%. Then initially we dilated with the 2.25 mm balloon. Subsequently, we applied the DEB 2.25 into 25 mm magic touch, and post magic touch, you can see extremely good result of the LAD. Now it's flowing very well. So the long-term patency is assured with kind of treatment. This lady, 65-year-old female patient, and prior to the index procedure, we did the T-stenting of the left main bifurcation. You see the 2 years later, she came with a recurrent angina. L6 was totally occluded. So with great difficulty, we could cross using the Gaia 1, 2, and subsequently. Previously, what we did, T stenting, and in between there was no stent. Distally, there was another stent. So what we did, in between the stented portions, we applied the DEB, that is magic test 2.15, where in between the previous stents, there was a bare area which was covered with DES. And proximally, what we did, proximally we put the DEB kissing for this patient. So we thought of putting the LMCA to LAD and L6. This is a 2014 procedure. You can see the occlusion totally. And this is the previous procedure. Now we did the cutting balloon preparation and 2.49 ostial LCX. See, very, very tight. And before cutting balloon, it was 2.49. And you can see the lesion area is 2.4 square mm before cutting. After scoring, you can see very clearly, nicely expanded 5.2 square mm. That means a very good expansion area. And we treated left main bifurcation with 2 DEBs. So after DEB, we got a very good luminal area of the left main and LAD area and L6 area. L6 area, you can see 5.6 mm. That as per the IBHRE studies, L6 ostium 5.6 square mm more than m, but 5.6 square mm. As per the OCT, 4.5 square mm. But now distal LMC area is 18.4 square mm. And the stent is nicely expanded. You can see the 2 layers of the stents and absolutely very good expansion of the area. This case was done near 2017 we did, and as of now, she is doing extremely well without any problem. So this is the OCT analysis. You can see the very tight narrowing of the L6 before and after expanded very well. And this patient, previously we did a long stenting of the left main to the LCX. And this we did the DK crush and extending from the left main to OM, and then DK crush stenting of the L6 bifurcation. You see, subsequently, this is about 5 years later, patient developed severe restenosis because of the neoatherosclerosis. You can see the OCT analysis. There is a severe neoatherosclerosis of the LCX proper. And there is a lesion at the LCX bifurcation also, but maximum involvement the LCX at the bifurcation site. So then what we thought, because already 2 stents were implanted, better to use the 2 DEBs. Then angiosculpt was used to prepare the lesion of the both LCX and OM expanded well using the NC balloons, and subsequently 2.75 NC followed by 2.75 DEBs. 2 DEBs were used for the kissing. So this is the final OCT. OCT showed a reasonably good expansion, and subsequently almost 4 years of follow-up without any significant recurrence of symptoms. So this is the final case, and a female patient, 86-year-old, recurrent angina, came with a congestive cardiac failure, severe mitral annular calcification, severe MR. Then what we thought, we'll go with mitral valve transcatheter therapy. Before that, we thought of doing the LCX and LAD. Both wells are severely calcified, very tight lesions. Then we did the, with IABP support, we did the orbital atherectomy of the LCX, followed by IVL application of the LCX as well as LAD. Both were treated with IVL as well as orbital. After adequate plaque preparation, then you see that we did because the LCX is having a tortuous bend, very old patient. Why to use the stent instead of that? In 2 stents, if we are using, more likely the MACE rate is going to be very high. That's the reason we use the stent to the LCX, LM to LCX, LM to LAD, proximal stenting, and we applied DEB to LCX. So Synergy Megatron was used. This is a final case, doctor by profession, came with acute anterval MI, LAD total occlusion. We did the OCT showing a diffuse fibrotic lesion, and RCA is normal. Then we proximal to mid LAD stented, but distal LAD diffusely diseased. You can see that. So where we used 2 into 30 mm protege DEB, and after DEB, now the LAD is flowing very well, and patients LAD function also improved well. As of now, we did total number of patients underwent DEB is 120. ISR patients were 55. We used for 65 DEBs for small vessels, and left main we used for 9 patients. Left main DEB was used in 9 patients. LAD was used in 69. LCX was used in 21 patients, and RCA 26 patients. Grafts, we did even a DEB for grafts in 33 patients. And total side branch were treated were 24, and Magic Touch balloon was used in 95 patients, Protege in 20 patients, Alex 18 patients, Oasis 10 patients, Agent in 8 patients, Mosaic in 1 patient. So to conclude this talk, DEB produces a more homogeneous strangulation into the tissue, no risk of stent thrombosis, no stent strut across side branch ostia, short adaptive duration, and potential of allowing vessel to function normally. So, so if you choose the patient very carefully, DEB has an immense role, particularly in ISR lesions, in bifurcation lesions. Instead of going for 2 stent, you can go with a single stent where the MACE rate is going to come down. And distal diffuse lesions, definitely this has immense, particularly in India, where the diabetic population is there. Most of the time we come across the diffuse long lesions. In such cases, definitely with adequate preparation, if you do the DEB, long-term results will be better. Thank you one and all for paying the attention.
Thank you, Sridhar. Your talk is very, very provocative and tantalizing, I would say, at the same time, because we have moved from distal diffuse to mid to proximal to left main. I'm sure that will raise many questions. So my question to you, if you have a stent inside, which law you follow? Murray's, Finney's, Kassab, and what is your fractal ratio of giving the final MLA on OCT versus IVUS on DEB? Is it 5, 6, 7, 8? Is it 7, 8, 9, 10, 11.8? Where the fractal ratio of the Kang recent study is 0.68. And what law you follow? What is your fractal ratio in your cases?
So based upon imaging studies, if you take the all IVUS studies, the meta-analysis, everything, non-LM bifurcation like LAD, L6, RCA, if the vessel diameter is more than 5 vessel area more than 5.5 square mm, associated with very good long-term results. With OCT, 4.5 square mm. That is non-left main. If it is a left main bifurcation, because the the Korean study, they have shown like, as you mentioned, 8, 7,
no,
6,
I'm talking about
5.
DEB. I'm not talking about stent, sir. I'm talking about DEB in ISR. What is
Whether
the ratio?
DEB or DES, by DEB does, the luminal area, it matters. 1 square mm achievement of the MLA, there is a 14% reduction in the ISR rate. So bigger the better, whether it's IS, always always achieve the 90%, at least 80%. If it is less than 70%, luminal area is not that good. Provided if the severe calcium, if you are unable to achieve, leave it. But always the criteria is same, better, bigger is the better. Every 1 square mm achievement, there is a 14% reduction in the MACE rate.
Sridhar, you have a question from, Dilip, yeah.
So, Dr. Kasturi, thank you for joining, and Dr. Dilip Kumar here. So just
Thank you very much, sir.
One query. So we saw you doing KISS with 2 DEBs, and this is one of the commonly asked question, and commonly, there is a confusion about DEB and the kissing. And Bruno Schellers clearly, tells that it should not be done, because when you're doing kissing, the opposition of the proximal segment of the balloons are not going with the wall. So what's your comment on kissing in bifurcation with drug-coating balloons?
No, actually the drug diffuses. See, most of the time we don't extend too much into the main vessel. Why? Because we don't want to waste. So anyhow, NC, everything preparation is done. So at least 2 to 3 mm will extend into the main vessel. So unless the confluence area is not, without kissing, this drug will not percolate into the main branch ostia, side branch ostia, and main vessel. Definitely, we have to apply the kissing balloon. Otherwise, I personally, this patient we did about 8 years back, that left main bifurcation. Even today, she is doing extremely well. We started doing.
This is a very hot topic in this time EBC club meeting. The same thing was discussed, and it was a consensus that it should be a sequential DEBs, and then if you want to kiss, it has to be by 2 NC balloons. So I think
actually,
there are some,
if you see the randomized trial, the data on the DEB is very less. To be frank, even if you take the meta-analysis also, the dialysis registry, 9,000 patients in pooled data. The number of patients are less, but frankly, it is reaching to the endothelium or not. Is it touching the contacting or not? That matters. I think
Sridhar,
that is the most important. Lesion preparation is the most important thing.
Sridhar, any experience on Medina 001 type of lesions with DEB only?
So we are using for the such case also. Ideally, that is the ideal indication.
That is the
What
best
happens
indication.
if the side branch is very tight lesion? If you are using the stent, sometimes you may think it is precise. Most of the time when we do the imaging, the stent starts projecting the main vessel, and that lead to the future MACE rate.
Right.
In such
Dr.
cases,
Ganguly.
prepare the lesion.
One
Dr.
important
Ganguly,
question, Sridhar. There particularly Anthony Colombo, Patrick Sir published an article, you know it. The IBHRE guide decide the size of the drug-coated balloon according to vessel size. This shows that both MACE and the TLR are significantly lower compared to without OCT.
Okay, so image guided, then Dr. Ganguly?
Yes, I was also asking the same question. How do you size the balloon? By angiographic view or by imaging?
Imaging mean IBHRE and OCT?
Anyone.
Both.
Anyone.
OCT or IBHRE?
Sir, for DCB, if you are doing intravascular imaging, that is the ideal method. Why? Because we know the exact vessel size. Even ACC, the DCB consensus group also very clearly mentioned, wherever possible OCT or IBHRE do it, vessel sizing should be appropriate. 1:1 is very important. It also rules out any important dissections. So up to C you can ignore, because those dissections can heal very well. But beyond that, flow limiting dissection should be addressed.
Right. So he's, I think what I could gather from his talk that DEB still can be done in left main. The only indication in my series will be those people who are having high bleeding risk and those who are having left main ISR. 001 is the ideal indication. So these are the 3 indications where I can think about DCB, but definitely it's a thought-provoking talk. Extremely beautiful cases, and I'm sure in future we'll have more such cases, but it will definitely invite a lot of criticism by a person like Dr. Subhanan Rai, sitting here, judging you here, observing you here, Sridhar. Thank you very much.
Sir,
for
these cases are not recently done, almost 7-8 years.
But even
follow
then,
patients,
its
what I
eye-opener
showed.
is very beautifully done, very beautifully executed, and confidently presented in front of the critics. Thank you very much for your...
Thank you.
Thank
Thank you,
you
Dr.
very
Sridhar
much.
again.
Thank you.
And Dr. Chaudhary, please join on the stage. Dr. Ranjan Sharma, sir, please. Please be there, sir. Deopriyo, please join. Please come, please come.
So we start the session with Dr. Subhanand Rai. He will talk on leave the right agent behind.
Thank you, Dilip, for inviting me to give this talk. This is leaving the right agent behind the de novo lesions. I will be talking on DEB and only on de novo lesions. So this is a PCI history, but that everybody we know that initially Grunji came with a balloon, and this is the gold standard still. Why? Because accepting the restenosis rate, it has got no other complications. Then the balloon angioplasty had two great problems. One, the acute reclosure, and number two is the restenosis. And accepting these two complications, the balloon angioplasty is rather harmless. So to prevent the acute reclosure came the bare metal stent, and we know that in bare metal stent we have reduced the restenosis rate to some extent, not much, but we could reduce the acute reclosure. But again, to reduce the the restenosis rate came the drug-eluting stent, and we know that the drug-eluting stent is not the ideal platform. And what is the problem with drug-eluting stent? Everybody knows here that it is related to very late stent thrombosis, and it is a very significant late thrombosis that is 0.3% every year, and by 10 years about 40% of stent occlusion or stent problems can happen with drug-eluting stents, even with the second generation, third generation drug-eluting stents. So very late stent related events occurred 1 to 5 years after PCI at the rate of 2% per year. This is a very significant rate. So what could be the answer? The best of two worlds. Number one, the best of balloon angioplasty without the restenosis and without perhaps the acute reclosure. But still, acute reclosure is a matter of dissection, and when we use balloon there is a controlled dissection, but when the dissection becomes uncontrolled, the acute reclosure happens. And there we cannot avoid stenting, but still in other cases where we can have a controlled dissection by balloon, the best probable benefit can be accrued from a drug-eluting balloon. So these are being discussed at large by my other speakers. I am not going into it. You know that it has got three components. Number one is the balloon, number two is the drug, and number three is the excipient. Why excipient? Because when you go through the arterial wall and you do not lose much of the drug during transit, and whether the drug can be given during the process of inflation inside the vessel wall. That is the most important thing. And of the drugs we have discussed so long about sirolimus and paclitaxel. I am not going into the details, but the DEB success depends on the reducing the drug loss as using by excipients, uniform drug transfer to the tissues, and retention into the tissues. And how long the retention should happen? This is a very important question. And we know that the drug restenosis happens within the first 1 month. Whatever the incidences happen, it is 1 month, but still the process of restenosis can can continue up to 90 days. That's why 90 days is important, but I think the first 1 month is very important. If the drug is present in the system, in the vessel wall, in the first 1 month in adequate quantity, then the restenosis rate will be 0. So, all DCBs available today utilize paclitaxel because as we have already discussed, and paclitaxel remains in the tissue for a long time as it is lipophilic, and less crystalline coatings, that is amorphous, have resulted in better uniformity, but nowadays, as I have already discussed, it is microcrystalline, and this I am not going into it. So it can be used as a drug inside the vessel wall, and this drug can remain in the system and the vessel wall for at least 90 days. So this is the drug and the balloon. This is by Boston Scientific, and this is a transpax coating. That is, they create some microneedles, and when you inflate the balloon, these needles are inserted inside the vessel wall, and from the vessel wall, the paclitaxel goes into the lipophilic tissues and remain there in much less than the toxic level, much lesser than the toxic level, 100 times lesser than the toxic level, but adequate level for at least 90 days. So these are discussed, I am not going into it. This is also discussed. So clinical settings, this is also discussed, but the most important is nowadays instant restenosis is already established. Now the 3 things are remaining. Number 1 is small vessel disease, number 2 is bifurcation disease, number 3 is osteal disease, and perhaps acute coronary syndrome. So consider DCB as this is the indications of DCB in the consensus. Consider DCB as a default strategy, except in the hemodynamically challenged cases where there is rhythm instability or hemodynamic instability in ACS, there should be stent should be used. Otherwise, in STEMI also you can use DCB. Patient-centric strategy, high bleeding risk, near-term surgery, anticipate DAPT, non-compliance, you can use DCB. Lesions perspective, feasibly POBA lesion preparation is optimal. It's a stent-like result, no recoil, no bad dissections, FFR more than 0.8, tolerant to minimum 30 to 60 seconds balloon inflation. There you can use DCB, and DCB only, and DCB plus stents is always there. So this is a paper which shows that paclitaxel coated balloons, this is a question asked that whether it can be used in STEMI. Yes, it can be used in STEMI. This is a paper. So I can, show, this is also being discussed by Sridhar. I'm not going into it, I will show you a case. This is a 52-year male patient admitted with STEMI. And this is the angiography. And you can see that there is a significant left main disease, as well as the lower part of the circumflex is lost. There is some amount of disease in the LED, RCA. So actually the culprit lesion is the distal part of the circumflex, and we thought of doing the case, planned to put a stent in the LCX and LMA bifurcation, and stays PCI and stent to RCA. So we open the artery. There is a 2 into 12 millimeter balloon and good lesion preparation, and after that, this is just like this. Then we put a agent balloon, 2.5 into 20 millimeter, and we did the left main and put a stent there. So it is a report, etc. And we did a angiography after 3 months. And you see that this is the lesion. This is the lesion, all are same. There is some amount of disease again in the distal part of the stent in the LAD. But the lesion, but the DEB, which we, the area where we did a DEB is excellent. There's no problem. So, LCX and OMs, no significant restenosis, and the patent LMCA stent, and PTCA was done with DES to RCA. So, wrap up, the first PTCA in large coronary artery was performed in 1977 as an excellent long-term outcome. Although currently being default strategy in coronary artery disease, DES show a continuous yearly event rate of 2%. Specific randomized data for DCB in de novo large coronary artery disease lacking, but published data from observational studies and previous randomized control trials looks promising, but still it is less than DES. Since a pure DCB only approach in large coronary disease may not be feasible, a hybrid DES and DCB approach could be good solution to obtain improved results, and large randomized trials with clinical endpoints in all comer patients should be eagerly awaited. Thank you very much for patient hearing.
It was a very wonderful talk, Dr. Subhananda. For the benefit of all, just because you have a very large experience, I will asking you some questions. Suppose you are taking a long DEB through a large tortuous RCA for not losing the drug during transit. Would you advocate guiding catheter, number one? If you are doing a long DEB in a LED and you are taking the size of the distal segment, say 3 millimeter, if you take that DEB, the proximal LED can be larger than that. The drug diffusion in the proximal part of the LED may not be there. So how do you come across that problem?
It's excellent. Both questions were excellent. First of all, everybody knows, and we also know that the DEBs are not like normal balloons. It is slightly difficult to deliver. So basically, where you expect that the vessel is tortuous, it is better to have a guide zilla or guide extension catheters, and you can put the balloon in that place nicely. So you have to assess that. When you take balloons and when you are dilating, you know that you are having problems, so you take a guide zilla. This is number one. And number two is, I do not use a drug-coated balloon in 3 millimeter arteries. I always take less than 3, 2.75 at the best. So the most important thing is we measure the distal vessel and size the stent according to the distal vessel, because we can dilate the proximal part. So there is no significant rule here, but what I take, my 8-9 years of DEB, I just take the average. Like if it is 2.5 and 2.75 or 2.25 and 2.5, I take it 2.5 and go up to 6. This is my rule.
Take a risk of a
slightly over.
Sir, just a practical question. Suppose we have done a DEB and we have TIMI3 flow, and residual stenosis is also only 20%. But when we are giving contrast, the contrast is staining for maybe 15-20 seconds in that segment. Whether you are going to treat this or just to leave it like that?
No, absolutely. You cannot assess dissection, because whenever you use a balloon, there will be a slight dissection. Always there will be a dissection. Otherwise, balloon doesn't work. So how you know that the disease? I asked this same question to Antonio Colombo. So he said, a very intelligent question, and answer. That is, he said that if there is a dye staining, don't use DEB. Simple.
After DEB?
No, not after DEB. You use a plain balloon for plaque modification. See that whether there is dye staining. If there is no dye staining, then use the DEB. Because DEB, you are not dilating with DEB. You are putting the drug. Gently you are putting the drug.
Sir, I have one question.
Yeah.
So the most established indication of using DEB is one of the most is instant restenosis. And you are doing it IVA's guidance. So you have done all sort of plaque modification. But still in the most restenosed segment, you find a huge fibrotic plaque burden. Do you still want to use a DCB?
No.
So what should be your bailout strategy in that?
The best is, when this is also, it has come into the guidelines. That is, in a instant restenosis, if you see there is a huge plaque burden, it is better to use either ablative things for plaque modification first of all, and then after doing this, you use another stent, not DEB. DEB should be given where you can have a good plaque modification, and you use you have a good luminal diameter. Then you use a balloon. Otherwise, balloon doesn't work. FFR is okay, but you are using this imaging, so you know what is happening.
Subhanan, recently published data from Korean study, they showed that the restenosis rate is almost 8% in DEB. What's your experience?
I cannot say what is, I have used around 30-40 patients. So it is very small data. But I must say I have used DEB in very careful way, and still I do not have a restenosis.
Right. All right, next.
So we thank you, Dr. Suvan Rai. So we go ahead with next topic by Dr. Dilip Kumar. Metal-less PCI, can this be made economical too? So we have an issue of cost. DES are less costly than DEB in India.
Yeah. So 2-3 important things I would like to just highlight before I go ahead. Dissections are not something which we should be scared of when we are doing DCBs. So dissections will be there, and we are sure that if there is TME3 flow and less than 20% stenosis, we are going to give a good result to the patient. And there is also an apprehension regarding acute closure of the vessel, acute thrombosis, when you leave behind after DCB. And there are 10 trials which evaluated acute closure of the vessel, acute and late thrombosis, and this rate was 0%. So this is totally a fear which has no ground to stand on. And that is the reason why DCBs are really sought after, and it is being talked about, and it's about a projection that 2030 will be 60% DCBs will be using, 20% scaffold, and only 20% will be using stents. So with this, let's go ahead, if things are economical also when we use DCBs. So these are the criteria where after the balloon or the lesion preparation, either by cutting balloon or by NC balloon or by plaque modification, if you get a result with less than 30% residual stenosis, TME3 flow, up to type B dissection, you can go ahead with DCBs, and that DCBs are like painting the vessels with drug. It's not like inflating, it's just like painting and delivering the drug there, and you have to be gentle and up to 6 or 7 atmosphere pressure. That's just the company tells you the average pressure which should be given, not beyond that. It's not just Dr. Sivanan Rai just told that it's not a balloon with which you are preparing the vessel. It's just painting the vessel with drug. So these, and you can see if we use cutting balloon, they say that drug reaches the media and the intima and the adventitia more, and that's why the results are much better. So wherever possible, a cutting balloon is good or angiosculp is good when we are doing DCB. So I will be just taking you all through some of the cases which we have done, and couple of them were CTOs, and I will show you the results. So this patient had a bypass surgery done, LAD Lima was working, but the large diagonal had a proximal disease, and 2 OMs were badly occluded. And we prepared the vessel with NC balloons, and both the OMs were given drug-eluting balloon. And the same DEB was given. Same DEB we can give up to 3 times in a patient, and we can have a good result and acceptable result. And this was the final result of the patient. You can see the patient is still doing well, and the OMs are flowing circumflex. Proximally we gave a stent. So 2 OMs were given DEB and proximal stent. This was a CTO of RCA, and we opened that with Gaia wire. And once we opened it, it was a diffuse disease. You can see here, it was an all IVUS. We did not have a plaque-free area, so we chose a distal RCA segment where the plaque was around 20-30%. And we parked our last stent there, 3rd stent, and then approximately we kept on stenting. And then this was the result. You can see distally we were again nowhere. Now this segment we did drug-coated balloon after dilating with NC balloon, and then finally we got a result like this. And this patient is also doing well. So this is a hybrid strategies where distally there's a diffuse disease, we can go for a drug-eluting balloon. And this was a patient who crashed in medical ward, medicine ward, inferior wall MI, and you can see we did the angioplasty of RCA quickly, and the patient went home with this result. And after 3 months, we took the patient for LAD and circumflex angioplasty. Circumflex we did with stent, and LAD there was a akinetic segment, so I was not sure about the viability of the apex, but we were very concerned about the diagonal segment. It was a large diagonal segment. So we crossed the CTO LADs, we crossed LADs, diagonal was already flowing, and then after ballooning we were not getting any flow in the LAD. So we decided to stent this diagonal, and it was wait of 10 minutes. We did the IVUS, it was all diffuse disease. And then again, we thought, let's do a little more work. We waited again, then we saw some flow, and then we did a drug-eluting balloon to entire LAD. And then we saw a dissection in the proximal LAD, and we stented, and then we did a kissing balloon with 2 NC balloons and 1 stent balloon. So 1 NC balloon there and stent itself there, stent balloon there. And this was the final result after the optimization. Entire LAD was given DEB from mid to distal, and proximally where the dissection was there, we did a stent. And this patient's ejection fraction is now 60%, and it was once 30% only. So gradually with all stage interventions. So, and DEB was given, and finally one case where bifurcation, we have the best strategy is to put to cut with a cutting balloon one of the side branch, give a drug-eluting balloon there, and then finally main vessel was stented RCA. So this was the main vessel stented after giving cutting balloon to RCA, PLV ostium, and drug was given, DEB was applied there, and this was the final result. So this is the best possible result in bifurcation you can expect if you see a good vessel with no residual stenosis in the side branch, done by cutting balloon, given drug, and the main vessel giving only 1 stent. So 1 stent and DEB. This was also a CTO of the RCA, diffuse disease, and we just gave drug-eluting balloons, and then finally the patient was left with this result. Entire vessel was diseased. So these were again CTOs, opened and diffuse disease were given only DEBs, and the patient did well. So what is an ideal DCB? Ideal DCB should have a anti-proliferative drug which reaches quickly, stays there, and the dose should not be toxic, and this is what we require. And paclitaxel, we have extensive talk by Dr. P.C. Mandal. I'm not going into the characteristic of this drug. And this is how it is eluted. In 10 to 15 days, most of the drug is eluted, unlike the drug-eluting stents where it takes 90 days to elute. And most of the trials till now, they are done with paclitaxel balloons, So you can see here how many studies have been performed, and this was a Transform 1 trial, which was I was just highlighting. Transform 1 randomly compared sirolimus with paclitaxel, and they measured the distal enlargement, lumen enlargement, where paclitaxel is expected to give better results, but clinically there was not much difference, no difference. So this, the paclitaxel company, this is drug companies, DCB companies, they highlight this Transform 1 as their plus point and USP, but you can't clearly state that, because this is a normal thing which we know, that we get a more lumen, but clinically there is not difference. MACE, TLR, there was not much difference. And positive remodeling happens with paclitaxel, which we had extensive discussion. And Protege has a unique windshield technology where the drug is folded. So once you are going inside with lot of injury, the drug is not getting decimated. So this is one benefit. And once you inflate, the drug is homogeneously going into the wall, and the drug, the excipient acts like a sponge. So once sponge is given pressure, only then it will give the drug. So it's a very good technology, and it ensures homogeneous delivery of drug. And this PVP coating acts like a sponge. And this is tightly wrapped, so it's drug is not decimated on, it's not, distal embolization doesn't happen much. And there is a M3I technology, 3 inflations, and still you get drug concentration in the wall that is 1 microgram per millimeter square. That is more than enough to give you the final result. So we have got Pearl registry with Protege, and we are waiting for some large RCTs. And finally, the the cost effectiveness. So this was one study which evaluated that if DCBs are used, what is going to be the cost to the patient. And you can appreciate here DCBs, 294 euros initial procedure cost, and over 12 months is around 1,174, which is far less than a drug-coated stent. With this, I conclude my presentation. Thank you so much for the patient hearing.
Dr. Kumar, your although there is no MACE difference, but your choice of DCB is paclitaxel.
So I can't say, sir. At this moment, I really tell you, after doing more review on literature, it's absolutely not clear that which is going to perform better. But
so
late lumen enlargement happens more in PC, and toxicity part was once claimed, that also it is not being seen now.
So if the difference is not there, if you are doing a side branch with a DCB, and main stent you are doing mostly sirolimus or any limus drug. So will you doing limus for side branch only, DCB?
Yeah, I think it doesn't create any difference, sir.
Because you will have a dual drug in the
dual
proximal
drug,
part. In proximal, that carina segment, you will have a paclitaxel plus limus drug. And if you take a DCB, which is limus, then you will have a only limus type of drug.
But no one there's no study which has shown that it is going to create any clinical difference. Yeah.
Anyway.
In a substantial bifurcation stenting, do you like to finish off where you have used a DCB in a side branch and you have used a stent in the main branch? Yeah. Do you like to finish off your stenting strategy by a final kissing balloon?
It's not absolutely necessary here. So cut, do a DEB, main stent, pot, and you see a good result. It is not a 2 stents which are there which has abnormal carina. So you can leave like that. It's simpler and as well as more effective, I feel. Yeah.
In this EBC 2024, they have presented a trial where they finished off the decay crush by doing an FKBI, even after using a drug-coated balloon in the side branch.
Yeah. So what was the result?
So it was there. It showed that FKBI is required. This was there.
Okay. These are more, I think, eminence-based than evidence-based.
So 1 or 2 trials doesn't. Yeah.
How comfortable are you with this balloon technology, which allows you multiple inflations, and then they tell you that it will be the same drug delivery?
I can tell you after 6 to 12 months. You can also tell us. So we are all using that. And but good thing is that they say that these are folded like that, windshield, and the drug wasting is less. So the more amount of drug which should be delivered right there, in the vessel wall, it is being delivered there. So, no, yeah, so it comes down, but still the lowest one is also 1 microgram per millimeter square, which is the like dose which is required for.
So when I'm doing 2 inflations, suppose, so how can I be sure that I'm delivering the same amount of drug in the proximal segment also?
No, it's 90%, 70%, 30%. But this 30% is also more than 1 microgram per meter square. Yeah.
No, it's not that. It's the, I mean, the last inflation, whether it will be effective, because, you know, for the first day, you need a much higher dose of drug, because some part of it will be washed away. So, whether that 30% will be enough, I don't know that.
So if you have to
another question, Dilip. Dilip, just a moment. In cases of the transform 1 study, the sirolimus actually failed to show the non-inferiority.
No, sir, that
in
was
concern to late luminal loss.
Yes, sir, it was all late lumen enlargement, sir. But clinically the results were
There is
same.
no difference.
No difference, sir.
Though the early study failed to demonstrate
So
non-inferiority.
this is expected, sir, paclitaxel balloon will give a little more large lumen. But clinical, end point is more meaningful,
But
sir.
it is negligible, 0 versus 0.32. Yes. It is a negligible one.
Sir, we'd request Dr. P.K. Hajra sir to be here for his talk. Solution for drug elution in DEB. Over to you, sir.
Hey, so thank you, Dilip, for inviting me. There are some slogans in drug-coated balloon. The first slogan which strikes strongly in my mind, that is gain more, lose more. Gain less, lose less. That means you gain more with the paclitaxel coated balloon, 54% positive remodeling, and also lose more. You gain less with the sirolimus, 30% positive remodeling. Also, you lose less. So at the end of the day, probably both the balloons are equal as far as the mass and TLR are concerned. There are 3 drug-coated balloons which are sirolimus based. One is solutions. I started my journey with solutions. We have an experience of 50 solutions. Then it was out of market. We have around 200 plus, and most of them are paclitaxel. Strongest data is with paclitaxel. So there are 3 sirolimus coated drug-coated balloon. One is Magic Touch, Solutions, and Sequent New. Rest is paclitaxel and bioluminos. So here is the comparisons that the drugs are different, the drug doses are different. Drug doses are different from 1.27 to 1 up to 3 milligram. There is elution control. There is only 2 drug-coated balloons which are without any excipient. These are Protigi and Elutex. These are latest generations of drug-coated balloon. Most of the solutions and Magic Touch in animal experiment, the drug stays up to 90 days. The paclitaxel disappears as 30 days. So surface coating microembolisms is really an issue with larger particle, but has come down with nanoparticle and crystalline, microcrystalline, or amorphous, or surface coating. Data strongest with the paclitaxel coated stent, but solution is also gaining momentum. So as I have mentioned that the paclitaxel started with ISR, that is the non-controversial area. Rest is small vessel disease, non-controversial area up to 2.75. If you cross the boundary of 2.75 to 4 millimeter, then the controversy comes. Now case-free trial, case-free 1 and case-free 2 from China is one country trial, large number of trial, all are paclitaxel of different varieties. The trial is negative if you take the whole trial into context. But if you subdivide this case-free trial in 2 groups, less than 3 millimeter, above 3 millimeter, less than 3 millimeter, superior. If you include all the groups in one basket, perhaps it is not proven to be non-inferior. So that means still we do not know if you cross the boundary of 2.75 or 3, or the drug-coated balloon should be the default choice in large coronary artery, proximal, ostial, circumflex, 001, RCA, graft, lima, venous, we do not know. So there are excipients, as I mentioned, there are 2 drug-coated balloon. These are without any excipients. And there are countries who did the first drug-coated balloon where? In Germany, Bruno Scheller, he did the first drug-coated balloon. So he started the ISR. On the left, you have all ISR. PepCat 2006, ISR Desire 3, PepCat China, RIPS 5 Spain, Seduce Belgium, RIPS 4 Spain, TIS Czech Republic, DARE Netherlands, Restore South Korea, BioLex Germany, Latvia, Agent recently in US, Magical ISR will be tested. So numbers are very small to start with, 131, 268. Initially the non-equality trial or non-inferior trial. Follow-up is very small, 6 months, 9 months, that's it. Now we are heading towards 2 years or 3 years data. Then we come to the small vessels, Pico Leto, Bello in Italy, Antonio Colombo was involved in 2012. Then we have transformed 2 small vessel means 2.75, Eastbourne. Then we have many targets, like we have included bifurcations, we have included de novo, ISR, left main, these CTOs. So fields are expanding. And the numbers are not very large. If you go beyond small vessel disease to large vessel or CTO or lima or venous graft. So numbers are very small. So here is a patient of mine. This is 85 years gentleman who came with ACS. His RCA was having a proximal tight lesions. The troponin was 1000. He had 3 tandem lesions and the proximal one is very tight. The guide was damping, mid and distal. And this is the result after a hybrid proximal stenting because there was ostial lesion. The ostia of the RCA or left main is not the ideal for drug-coated balloon. So this is the distal drug-coated balloon. The sizing either 1:1 or 1.2:1. Mid, then proximal stent. And this is the yellow, this is done for the first time in Eastern India. His RCA was full of cholesterol, and once you put these drug-coated balloon and stent, the cholesterol disappear. So this IBHRE or hybrid can tell you whether you need just drug-coated balloon. Suppose you have a non-flow limiting lesions, you could just put a drug-coated balloon like a PREVENT trial. So here comes the solution SLR trial, number was 3326. So that means trial is still going. We have first 1000 patients data, and these are ACS patients, STEMI, non-STEMI, and unstable angina, excluded left main and graft. Flow limiting dissection, residual more than 30%. We still do not know what is the procedural endpoints in ISR, but we know the procedural endpoints in de novo lesions. The lesions should not be more than 30% residual, FFR should not be more than 0.8, either of it. If it suits both, that is the best. Now with the time, in solution trial, if you start with one center to second center, the one center does more, the second center does more. Gradually, over the time, the confidence of the doctors coming from the distal to proximal, proximal to left main, small to bigger, things are getting better and better. And the bailout stenting is also coming down because I have never seen any acute closure, 0 acute closure out of 200 plus DCB in my life. So these are different balloons, and these are different animals from the usual balloons which Grundig has used. You need to prepare bed in almost all cases of drug-eluting balloon. Whether it's cutting balloon or laser or rota, orbital, we have all types of cases with drug-eluting balloon. So to prepare the bed in solution trial, they have used IBHRE OCT. IBHRE is the best. Prepare the lesions, then you can apply anywhere, especially small vessel and diabetes, high bleeding risk. Some of the patients who cannot tolerate DAPT, it can be used. And the beauty, so there are some beauties of the drug-coated balloon. If you just mention, if you do the knee spectroscopy, of drug-coated balloon before and after, there is 70% disappearance of the lipids just by paclitaxel drug. So it is a statin-like therapy. So these are the things we can see in our NIT spectroscopy. And another beauty is buy one, get one. So you treat the main vessel, your side branch gets bigger and bigger with time. You do not need to put another drug-coated balloon in the side branch. So this is post-op, and at 9 months, the side branch gets bigger and bigger. And the MLA in the side branch, if you do sequential ballooning, it's fine. If you do not do sequential balloon, if it is 50% lesions, still it works, and the MLA grows over time. So there are 3 approaches with solution or magic touch. You can have a blended approach. You can have leave nothing behind, simple. And there are few things which can be done to deliver this drug better. You have to produce some dissections, less calcification or calcium modifications, guide extension, drug enhancement by excipient, guide extension catheters down into the downstream, prolonged inflations, perhaps up to 90 seconds, single effort deployment. If you have not able to cross, if you're not able to cross the lesions, discard the balloon, take a fresh balloon. Cutting laser mentioned, dissections, less friction, that is, should not use a 5-inch catheter, rapid transient time, a little oversize like 1.25 to 1 definitely helps in. You can see these dots settling down immediately. This microembolization is an issue with the paclitaxel. You can see in OCT. So, ladies and gentlemen, this newer technology is gaining momentum, and perhaps you will not see anything left behind. It's just a painting. If you want to see behind the scene or behind the portrait, you will not see anything. Thank you very much.
So you spoke of 2.75 and 3 as the cutoff of using. So one basic, this is something that I always think of. How is the vessel different at 2.75 distally and 3 proximally? How is it physiological or anatomically different? It's the same thing. I mean, so if we are able to, if the thing works at 2.75, it should work at 4 also.
Right. So if you lose a 2.5 OM, is not going to die. So hard endpoints are not going to change. The death is not going to change whether treat. But if you treat a 3.5, if the vessel closes or comes back with a mess, then you'll be questioned. So that's why you have a stent of 15 millimeter giants or any newer generation stent. The mess rate is almost 0. So why should you try to do a different thing when you know the TLR is quite promising and almost nearing 0? Only when you can do when there is a high bleeding risk or is a long diffuse lesion at the stent edge, you put a small best of the generation drug-eluting stent proximally, then you treat the rest of the lesion 2.75, 3 millimeter down the line with another 1 or 2, 3 drug-eluting balloon. And if you put the drug-eluting balloon in 2.75, 3 millimeter distality, if this man needs a surgery in the future, your vessel is prepared like a, this scaffold.
That's right, but for STEMI trials on DCB, so the vessel size must have been less.
Okay, the solution is a STEMI. Any vessel, any size.
No, STEMI you are doing, most of the times we get 3.5, 3 vessels.
You can do, but up to 4 millimeter you can do.
So in STEMI trials, DCB, their vessel size are largest.
Yes. Yeah, so the Revelation trial, only 71 patients, but they have tried up to 4 millimeter. Beyond 4 millimeter, do not have any stent. So do not have a DCB.
Actually, comparative study of the giants versus paclitaxels, this shows the TLR is low and MACE is low compared to the giants.
So are you talking about cage-free trial?
The 3 important study you have to keep in mind, that is the DCB is superior than the drug-eluting stent. 3 important study. First study, one is the paclitaxel versus giants. Important study is there. TLR is low.
Are you talking about small vessel? No, you have to decide whether you're talking about small vessel, ISR or all comers.
No, all
comers is case-free trial.
Similarly, Resolute versus paclitaxel, Resolute marginally lowered the restenosis rate, MACE is same. Again, Liberty, that is the paclitaxel coated stent, drug-coated stent versus drug-coated balloon. These also shows the TLR low and MACE is low. So therefore, we are happy to use the drug-coated balloon, no doubt at all, compared to the important stent.
So in the interest of time, I think if
Fine,
we can
yes,
move
yes.
on with the next presentation. I may invite Dr. Ramesh to present.
Study only, the angiographic study is only 6 months and clinical study for 12 months. That is important.
Thank the DEB Conclave for the opportunity. So today I will be talking about predominantly, so most of the initial slides are spoken by other speakers. So I don't go into what is the advantage of DCB and DES and all, I'm not going to talk. And I'm going to talk predominantly about the guidelines and what are the important landmark trials that has come in DCB. And the guideline recommendation now is 2018 ESC guidelines tells us that drug coating balloon are recommended for ISR. The evidence is class 1. And then there is a paper by Italian Society of Interventional Cardiology where more of a DCBs are done. And DCB is recommended for bare metal stent restenosis, that is class 1. But DES restenosis class 2A, and a small vessel as well as bifurcation, it is class 2A. And what the German group tells is, again, it is recommended for ISR management as well as small vessel as well as bifurcation, it is recommended. And China expert consensus also tells it is recommended for ISR, small vessel and bifurcation. So there is a lot of discrepancies between different groups, but what we see uniformly, it is recommended for instant restenosis, but it can be done for a small vessel as well as diffuse disease as well as bifurcation, it can be done. And what are the approved indications so far is instant restenosis, small vessel bifurcation and de novo lesions. And what are the prospective, like we had a lot of interesting cases where it was used for diffuse lesion, whether we can use the proximal drug-eluting stent and distal lesion, we can do a DEB. And newer indication like a heavy calcified vessel patient coming with acute coronary syndrome, you want to salvage, you can use a DEB. And acute coronary syndrome and particularly high bleeding risk patients where there is a prolonged DAPT cannot be given, there again you can use a DEB. And these are the different drug-coated balloons, and I think the last speaker has told about that. And these are the Limus drug-coated balloons. And these are the various trials that started way back in 2010 where it was a small number of patients were included. And when they found it was more promising, you can see after 2009, a lot of trials have come, and particularly this non-elute and Eastbourne, where more than 2,000 patients were included. And we'll see in subsequent slides what are the results. And Magic Touch is now approved in USDA also. And so these are the trials that was done, and that are complete trials are non-elute trial and a FIASO trial. I am not going to detail, I'll just rush through important trial. And the selfie trial is it's a small trial that was done in acute coronary syndrome. And Eastbourne is already released, and we already had a discussion about Transform 1 and 2. And the ongoing trial is UK SEB and Titan Ginger, and also a lot of trials are happening with the sirolimus eluting balloon, that is a Magic Touch balloon. And we'll see what are the important trials, that is Eastbourne registry trial, and almost 2,000 patients in European and Asian sites were included, and follow-up was done for 36 months, and the primary endpoint was a target lesion revascularization at 12 months, and secondary endpoint on MACE, and it was done in both the de novo as well as instant restenosis patient. De novo lesions were 1,000, and instant restenosis were 910, and you can see in de novo patients, whether diabetic or non-diabetic, you can see the MACE and the target vessel revascularization almost similar in diabetic as well as the non-diabetic patients. And instant restenosis also in diabetic or non-diabetic, there was no difference. So again, the MACE rate were lower. And another important sub-study of the Eastbourne registry was bifurcation, where hybrid was done with the stent as well as the side branch drug-eluting balloon was used, as well as both vessels drug-eluting balloon was used. Like one of the question was that whether both vessel main as well as side branch you can use drug-eluting balloon, and it was used, and the all-cause death and MACE were almost similar, whether it was used for de novo or bifurcation. So it was not statistically significant, only the MACE rate was slightly more, but not statistically significant. So coming to the role of what are the evidence for diffuse lesions. So another indication is like in the end with diabetic we see a lot of diffuse lesions. So what is the indication of DCB? So and one trial that was done was DCB with the in de novo diffuse lesion. It was done in Italy, and it was called a long de novo LAD disease study. And one arm they used a hybrid PCI stent with DCB or DCB alone, and other arm only DES was used. And what they predominantly compared was the outcomes. And you can see the more diffuse treatment, you can DCB arm, the total treatment length was 65, it was slightly more, and the DES arm, the total length was lesser. And the large vessels, more than 3 also were used, DCB was used. So one question was whether larger vessels we can use, the larger vessels was used. And what was seen is dissection was more common with DCB, that we already seen dissection can be left. And high risk of side branch occlusion was seen with DES. And this was the endpoints. And DCB length in DCB group, 70% of the patient received a hybrid PCI, and 30% received only DCB, and the total length was almost 60 millimeter, and 58% of DCB length was greater than the stent length. So DCB length was more than stent length in the hybrid patients. And most important balloon, a large balloon was used, was Magic Touch in sirolimus, and paclitaxel was used. And a 2-year follow-up was done, and you can see when the patient was followed up for 2 years or more than 700 days, you can see the target vessel revascularization, lesion failure was more in stent arm. When a longer stent was used, the target lesion failure was more. And predominantly, lesion failure is predominantly in the need for target vessel revascularization again. So conclusion, DCB used for LAD PCI was safe and associated with acceptable rate of adverse events at 2 years, and DCB based approach was associated with significantly lower target lesion failure. And another this Piccolato 6 trial that was compared actually paclitaxel with DCB, and what of time I'll just rush through. And what they've done is pre-procedure QFR was done, and post-procedure again QFR was done, and follow-up was done for after 9 months. And this was the late function loss that was calculated from the Piccolato 2 trial, and it was done in Europe. And again, I'll just run through the slides, and predominantly what it tells is compared to whether it is a paclitaxel or drug limus eluting balloon, that late function loss as well as net gain was not much different between these two trials, balloons, whether it's a paclitaxel or sirolimus eluting balloons. And particularly important trials were a drug-eluting balloon in ACS, and there was a advantage of DCB is there is no stent, so late stent thrombosis and all doesn't happen. And the late advantage is endothelial healing will be better because absence of metal strut. And the trial that was done is a nanolute trial, and it was a clinical follow basically at 1, 6 and 12 months. And predominantly ACS was done in almost 50% of the patients are ACS patients. And you can see the sirolimus coated balloon was used in 92% of the patients, and the balloon size was 2.7. And here again you can see the clinical outcomes at 3 years were very less, like MACE as well as MI and cardiac death was less. And another trial that was done in ACS, particularly in complex patients, but only less number of patients were included in this trial. It was only 62 patients were included. And you can appreciate the characteristic and the DCB diameter. So one question was, what is the DCB diameter in acute coronary syndrome? And in this trial they used 2.6 plus or minus 0.6, and the length was shorter length, and angiographic success was, immediate success was good. And you can see at almost 12 months the MACE and the target revascularization and cardiac death was less. So DCB is an option, particularly in a complex patient with a lot of calcium, where you can put a stent immediate period where the stent thrombosis risk is there, then DCB can be used. So thank you for the opportunity once again.
any query? So now I thank you. Now I invite Dr. Aftab Khan. Another stalwart cardiology from India, Dr. Aftab Khan. He will be talking on experience with Prevail.
Thank you, sir, for these kind words. I think I'd like to thank Dilip also for organizing this. The advantage is that since I'm speaking later throughout the day, much of the knowledge is already percolated and it will become easier for me to have this talk. So my talk is on experience from Prevail, that is the drug-coated balloon from Medtronic. So I'll start off with a clinical presentation of a case which is a 76 years old man who had stage 3 CKD, had effort angina for the last 3 months, and had crescendo angina with rest episodes now. A CAG was done elsewhere, and the patient was advised a PCI and was started on dual antiplatelets, and this was aspirin and clopidogrel, but had an episode of melena, which dropped his hemoglobin from almost 11 to 6.9, requiring blood transfusion, and then he came down to our institute for further evaluation. The gastro guys did a complete workup, which included CT scans and upper GI and lower GI endoscopies, but all they could find is tiny proximal ileal ulcers, and these were not really contributed to us. Endoscopy, capsule endoscopy was also done, and this also did not help too much. The patient had a normal ECG echo, which showed an ejection fraction of around 50%, creatinine of 1.7, and troponins which are marginally elevated. So the right artery was dominant and normal, and this was his left coronary system. We can appreciate here that there is a significant osteoproximal disease and 2 more lesions in the mid and the distal part of the circumflex arteries. This is a co-dominant vessel supplying a major part. And in the iliocranial view also you can see that there's significant osteal disease. Now you can also see that there's some plaque in the osteoproximal part of the LAD also, and this becomes a challenge for us. I got an opinion of a heart team approach. I think most of us would say, why would you send a patient with a single vessel disease for a CABG? But we also need to understand that, yes, that is one of the criteria also. So if you have a dominant significant vessel causing ischemia, that's a class 2 indication for a CABG also, or we had a PCI as an option. CABG was refused by the patient, and therefore the problem I had was this gentleman had the ARC criteria for an HBR. So he had 1 major and 2 minor criteria, spontaneous bleed requiring hospitalization, transfusion, as with this patient we said. He's had an age which is elderly guy with a renal dysfunction. The app that we commonly use is the ARC HBR app, and this is an app which helps you to understand the thrombotic risk and the bleeding risk. So with the fact that this patient had a 1 major and 2 minor criteria, he gets into a high HBR score. And then when you do a bleeding versus thrombotic face-off list, and you have this, the last slide there, the last frame there, you can see that there's a gray area, the yellow area, and the mid part, which is a bluish area. So this patient basically falls into the bluish area, which is an equal thrombotic versus a bleeding risk. So he has an equal risk of a high bleeding risk as well as a thrombotic risk also. If he had a greater bleeding risk or a more thrombotic risk, your treatment options could probably have changed. So here I'm stuck with an option where I need to do a PCI, but I have an option of deciding whether it is a DCB alone or is it a DES. Now we've already had a discussion, and these are just repetitions why we do talk about drug-coated, and we know that the guidelines usually talk about using either in-stent restenosis or in small vessel disease. And we have certain areas that we are now exploring, and this is a patient who has a HBR, as we said, and this is a patient who has a de novo lesion. Do we have data for de novo lesions? Yes, there have been studies earlier, and DCBs have been used in large de novo lesions, and we are talking about vessel size beyond 3. So we always have been using it in small vessels, but in large vessels also there has been data. And if you look at the line there, it's often preferred in circumflex lesions over a stent. And I think we don't need to understand why, because with a stent that you put in the ostial circumflex, if you try to do a precise ostial placement, there is still a 40% chance of restenosis. Whereas if you do a crossover from left main to a circumflex, we still end up with a 20% restenosis when we put in stents, and that's the reason circumflex is our Achilles heel. We already have discussed all this, and the drug or the DCB that I decided was the Prevail, and this again is the one from Medtronic. This has paclitaxel and urea as an excipient, and this is something that has already been discussed. There is something known as positive remodeling that happens over a period of time, and there's data to suggest why this happens. So we know that the vessel can grow, and that would be an important benefit for me when I'm treating the ostial circumflex. We have data from the Prevail, and again, zero thrombotic race and no slow flows, and there's a definitely, as I said, benefit as compared to stents when you use these drug-coated balloons. So for this patient of mine who had an ostial circumflex disease and 2 tandem lesions down also with a plaque in the proximal part of the LAD, I had planned to do an IVAS guided, made sure that there is adequate bed preparation, use a DCB, and in case of a bailout, it would have to be a stent, and it has to be a provisional stenting strategy. The concern would be on whether I use an SAPT or a short-term DAPT, because this gentleman has had a bleed on aspirin and clopidogrel, and really that would be a challenge for me. So this is the patient, and this is the lesion which we crossed with a standard wire. The IVAS would not cross, and therefore I had to use a small 1.5 balloon to pre-dilate the lesion, and an IVAS run was then made. And just for a short time, you can see the values there. So the smallest MLA is at 1.17 and 2.2 at the ostium. So we really have, and there's a mid segment that is at 5.18. That's the healthy area that we're seeing there. Not much of a calcium, but a definite fibrocalcific plaque. The calcium burden was not great with a calcium score on IVAS of less than 2. So this was treated with a balloon, and the balloon sizing was it's a 3 millimeter, 3 into 15 millimeters Wolverine balloon. And you looked at it in 2 different images. You look at 2 orthogonal views, and both of these show that the balloon is expanding well. The same 3 balloon was used at the ostium also, and we tried to make sure that we get the ostium well. And again, at 2 orthogonal views, we got a good lesion bed. Again, we did an IVAS to look at the images. There is a significant amount of remodeling, but the ostium still seems to show some amount of plaque burden. So after you've done a 3 millimeter balloon, we still see that there has been some improvement, but you still see that the plaque burden is close to 67%, still around 70%, which is not an optimal result for us. And therefore, further modifications was done with a 3.5 balloon. Again, this gave us a good result. And after we did an IVAS again, we were left with a plaque burden of around 40%. Now, again, we understand that when we say that you have to have a less than 30% plaque burden left behind, we are talking about angiographic imaging. We are not really talking about IVAS imaging. So I understand that we still left behind a 40% plaque, but I think we looked at the fact that if you tried a more aggressive plaque modification and we ended up with a dissection in the left main, I would be committed to a complex stenting with 2 stent, with this patient with a high HBR, we would be landing into trouble there. So the plan was then to use 2 drug-coated balloons. Why 2 and why not 1, as Dilip and others are discussing? Because there was a discrepancy in size, and therefore the distal vessel got a 3 into 30, and the proximal vessel got a 3.5 drug-coated balloon, and this is the Prevail. And the balloon opened up well. And this was the final image that we see. Again, you can see that there's some amount of plaque that is still there at the ostium. So this may not be the perfect result, but we still have a good flow without any significant dissection there. And I was happy to leave this patient with this. So this was how it looked before, and this was how it looked after. And the patient looked, I was happy with this result. The patient was then discharged on a single antiplatelet. Now, I know this may be controversial. We don't have data for an SAPT in a patient with with a stable coronary plaque. But again, this gentleman has bled on aspirin and clopidogrel, and that's the reason we decided to leave him only on clopidogrel. Been on a virtual follow-up for a month, and he's been angina-free with no overt bleeds. He's had hemograms and renal parameters are stable, and he's due for a check angiogram at 6 months or earlier if symptomatic. So this is something that I normally do for all our DCBs. We probably do a check angiogram at 6 months to see how the vessel grows, even if they are asymptomatic. So I'll stop here and be open to questions.
it was a good decision to can have a very short DAPT. We have stopped DAPT through trial and we can stop at 7 days even. But in a very long stents, it's very, very risky to stop at 7 days.
I understand, yeah.
So it was a good strategy. Thank you.
I think it was a cutting balloon circumflex or normal NC balloon?
It was a cutting balloon.
It was cutting balloon.
Yeah,
And I think all of us would have taken a LED wire, maybe
yeah.
you can afford to take a circumflex wire only. Because of skill.
After a very excellent result, I think the final result, some recoil in the proximal sarc. That
Yes,
is.
yes.
It is
I
not
agree
a
that, yeah.
calcium or other thing.
Yeah.
It is recoil only. It
Definitely.
will eventually disappear.
Hopefully, sir.
Okay, thank you, Dr. Khan. Yes, last comment.
Sir, this is a case of high bleeding risk. Yes, you had a residual plaque burden, so you left it like that. Yeah. In other cases where there is no high bleeding risk and you do a DEB there and you find a residual plaque after the IVUS, do you go for further plaque modification or leave it like that?
So I think, as I said, around a 40% plaque with an MLA that I'm getting more than this. I got an MLA at the ostium of around 5.7. I would be happy to leave it with a stent, without a stent, and leave it with only a drug-coated balloon, because I think at the ostium of the circumflex, we know that the stent results are also not too great. And therefore, we always can come back and fight it if there is a restenosis later on, rather than going with a stent and leaving it with a metal jacket at this stage itself. So I'd probably be happy to leave it, even if it is not an HBR at this stage, with only a DCB and the ostium.
Thank you, boss. And it was a wonderful session, and let's have a big round of applause for all the speakers. And we move on with the next session. We have another separate lecture on dual, antiplatelet strategy in DCBs, so we'll be getting more insights. And now may I invite the chairperson and moderators for the next session, Dr. Hema Rath, Dr. Imran Ahmed, Dr. Dipankar Ghosh Dastidar, and Dr. Anand Pandey, Dr. Saurabh Das, please be on. Subra Sekar, yeah. Subradip, please be there. Sir, ठीक है. बोल दो.
Dr. Rana, he's presenting for you. Very good evening to you. On behalf of Dr. Rana Rathore Roy, I'll be presenting. I'm Dr. Saurabh Das. I'll be presenting in his place. We would like to share our experience with our initial experience regarding the drug-eluting balloons. Our first patient was a 59-year-old gentleman who got admitted with complaints of chest pain and discomfort on exertion. His ECG revealed a T-wave inversion V2 to V6, and echo revealed a RWMA with LVF of 52%. And on angiogram, a double vessel coronary artery disease was planned, and he was planned for PTCA with the stent to LAD and DEB to LCX. Now, the LAD, we had taken a left femoral approach and using a usual guide catheter to engage the left coronary artery in cyan blue. And thereafter, we had basically the left LAD, we had taken a drug-eluting stent for 3×28 and deployed at 10 atmosphere. And the result after the stent deployment, we can see. But thereafter, we had decided to go for drug-coated balloon for the LCX. Now, the reason why we had chosen this patient for the LCX, because this patient had a issue regarding, there was evidence of high bleeding risk in this patient, and therefore we had decided that to reduce the metal burden, we'll go for the drug-coated balloon in the LCX. Now the cyan blue, we had crossed the lesion with the cyan blue guide wire and taken it to cross the LCX lesion. Pre-dilatation was done with semi-compliant 2 into 15 millimeter at 16 atmosphere, and pre-dilatation with also was done with 2.25 into 8 at 12 atmosphere. Thereafter, I will say we can see the results of the pre-dilatation. And thereafter, DEB, that is paclitaxel coated balloon, that is Prodigy 2.5 into 20 millimeters was placed for at 6 atmosphere for 1 minute. And thereafter, we can see the result. Post procedure, TIMI 3 flow was achieved in the LCX, and no significant recoilant dissection was seen. And we can see the results in this. There is a minor osteal plaque, but we see a flowing TIMI 3 vessel thereafter. In the second case that we are presenting, there's again a 59-year-old gentleman with a known hypertensive with diabetes, a PTCA with stent to LAD in 2019. He got admitted with complaints of exertional angina. And here again, I'm going to say his CAG had revealed that there was in the LAD a patent stent in the proximal part and a borderline disease thereafter the stent segment. And in the LCX, which was non-dominant, proximal long segment stenosis of 70% and OM1 and osteoproximal 70% stenosis. And the RCA, which was dominant, had a proximal to distal normal PDI and normal PLV. So with this, we had planned to go for a FFR guided evaluation of the LAD lesion and a PTCA with IVUS guidance to the LCX. The reason again we had chosen in this patient had a history of stroke earlier, and for high bleeding risk issues, we had chosen to go for the drug-eluting balloon. The PTCA was done through the right femoral approach, and guide catheter 6 French LBU 3.5 guide catheter was used. Now there was a difficulty in crossing the lesion. So initially we had to choose Fielder FC guide wire to cross the lesion with the support of a 0.75 into 8 millimeter balloon. And thereafter sequential pre-dilatation was done with 0.75 into 8 and 1.5 15 millimeter balloon at 16 atmosphere. And thereafter the Fielder FC was exchanged with cyan blue guide wire. Again, pre-dilatation was done to the LCX with a semi-compliant balloon at 2 into 10 at 14 atmosphere and non-compliant at 2.25 into 12. And thereafter a cutting balloon, that is Wolverine, was used 2.5 into 10 at 15 atmosphere. The result after pre-dilatation we can see, this was a slightly difficult lesion, it took us a lot of time. And thereafter paclitaxel 2.5 into 30, again Prodigy balloon, was used to cross the lesion. It took us some effort to cross the lesion with the balloon because of the calcification, but thereafter it was inflated at 6 atmosphere for 60 seconds, and then we can see the final results. We achieved, though it's not a perfect result, but we achieved a flowing vessel, and thereafter in the OPD follow-up, the patient's symptoms have been quite relieved. So the take-home message in our 2 short cases that we have presented here is DEB, like we are using it for small vessels, ISRs, and smaller vessels, and DEB is a promising alternative also in distal vessel and bifurcation. The advantage is less metal burden, dual antiplatelet can be given for a shorter duration, and like as Dr. Khan had said, like he started with the SAPT right from the very beginning. And the side branch patency in bifurcation lesion, that is again a place where DEB is has a place. Thank you.
Okay, nice case presentation. But put in a stent in LED. So in any case, you are going to use DAPT.
So, sir, in this case, actually, our experience with placing a drug-eluting balloon in LED was limited. So we did not want to go for a...
Why didn't you put a stent in the circumflex as well?
Sir, I must say, in our thinking, like it was reducing the metal burden. I would say
I think one answer you would have given was the main LCX was, I mean, the lesion was at the ostium of the OM.
Yes.
So that you could have the main LCX was, it's a kind of a bifurcation.
It is a kind of
so
a
that
bifurcation.
way you can, I mean, otherwise, what he's saying that there's no advantage from the platelet, anti-platelet drug point.
Point taken, sir.
Dr. Anindam, please, with the next case.
Thank you.
Thank you, respected chairpersons. Dear audience, so DEB is very futuristic, as we all know. We are doing regularly. I'll be showing shortly our data of this year's DCB use in my hospital. So before that, one or two cases, as Dr. Saurabh mentioned very clearly, few situations are very obvious that DCB is better than DES. Say for example, ISR, small vessel, ostial LCX lesion, bifurcation lesion, and in high bleeding risk. So these are the situations probably everybody will agree that DCB is going to stay here and its role has been proved. Now we are very futuristic. We think that in future the indication may further increase. So this is one such case. So patient angioplasty to LAD was done with 2 stents 1 year back only. So it was a drug-eluting stent, synergy stent. So what happened after 1 year? Recurrence of angina, and that prompted us to go ahead with check angiography, and check angiography showed very significant stenosis of the existing stent. So within a span of 1 year, this kind of ISR happened, and we are not very sure what exactly went wrong. This was a very good international drug-coated drug-eluting stent. So we thought, let us first check what's wrong, and second, we should treat that. Now, this was the IVUS pullback. As you can see, the distal stent was good, but now restenosis segment, we can see not much of calcification, mostly neointimal hyperplasia. So we can see neointimal hyperplasia is generally not seen in DES era. It's more common in bare metal stent, but still, something may go wrong in any patient. So this was the reason. Now what we did, we pre-dilated the lesion, as we are, doing good number of DEBs, drug-coated balloons. So our protocol is very simple. We pre-dilate all the cases with cutting balloon. Mostly we are using Wolverine. So this is a cutting balloon. You can see 3.5 cutting balloon, but as the IVUS showed, the pre-existing stent was also probably needed for the post-dilatation. So after cutting balloon, we went ahead with high pressure balloon, OPNNC 3.5, followed by non-compliant balloon, the ostium of the LAD, 4.5 non-compliant balloon. So with those all resulted in very good bed preparation, followed by a 4x20 Pro-TG. This is a paclitaxel eluting DCB, and the benefit of this particular DCB manufacturer, they mentioned that you can actually, after initial inflation, there is still some drug which is there, so you can actually go ahead with subsequent another inflation. So the exactly same thing has been done in this case. So initial balloon was done in the ostium of the LAD, followed by a further subsequent dilatation in the mid LAD as well. And we did a check IVUS. This was the IVUS, and you can see the final result. Everybody will appreciate very good end result, very good lumen gain. So as of now, it was done around 6 months back. Patient is doing good. No further subsequent recurrence of angina, but we are planning to do a check angio after 6 more months. So after 1 year, we'll do again an angio. So another drug-coated balloon, So the principle of drug-coated balloon is very simple, leave behind nothing. And there are two, mostly, though there are newer, generation of drug, but mostly paclitaxel and sirolimus we are using. So there are some basic difference in between these two drugs. So paclitaxel is lipophilic, whereas sirolimus is hydrophilic. Very important about paclitaxel, it's prolonged tissue stay, which probably is not good for drug-eluting stent, but that may be an advantage for drug-coated balloon. Whereas sirolimus, short tissue half-life, but less positive remodeling. There are some evidence which suggests that with paclitaxel, probably the positive remodeling may be somehow more. So I'll go to my second case. So this was a case of inferior MI, a very long-term diabetic lady, inferior MI. So on insulin for last 30 years, so we went ahead and did the primary angioplasty of the right coronary artery. And I'll show you the left system was probably not suitable for putting stents. So this was the left system. You can see the LCX, very calcified lesion. You can see the calcification, very significant calcification. So we went ahead again with drug-coated balloon, and you can see on the right-hand panel the final result of the after pre-dilatation with cutting balloon followed by drug-coated balloon. So LAD was also not very suitable for putting stent. Very narrow caliber artery. You can see almost like parallel LAD in the distal part. So we again went ahead with cutting balloon followed by drug-coated balloon. So this was the final result, and patient is doing good. So we also did a check angio of the right coronary artery, which was done 1.5 months back. It was flowing nicely. So this is few examples. So this is the list. I know it is not very clear. This is the list of my hospital's last 1 year's DCB. So we have done 40 patients, and to be honest, 41st patient. I just did one, drug-coated case right now, half an hour back. So 41 cases. So mostly we can see we used some paclitaxel, some sirolimus eluting stent, and almost all the arteries. You can see LAD, LCX, RCA, proximal artery, everything we did. One thing I'd like to say in this 1 year data, we have 0 target vessel revascularization. So that much I can tell you. None of the patient had to taken back to the Cath lab to do a check angio. So it's very early, but very encouraging result. With that, I'd like to stop here. Thank you very much.
I mean, all the indication, whatever you did was good. So how much importance is doing an IVUS before, and more important, the question is after you have done a DCB?
So very relevant question. So I make it a point to do IVUS in all my cases where I am planning to do DCB. So how my protocol is very simple: pre-dilatation with a cutting balloon, followed by IVUS, then putting a drug balloon, then nothing else. You do a simple angio. Now if your angio is showing there is no dissection, no dye retention, so dye is clearing immediately post angiogram, then that is done. So you are not supposed to do another IVUS post DCB. That is the protocol we are following. But it's very important to do a baseline IVUS followed by post cutting balloon IVUS.
Why not after the procedure?
Yeah.
What is the indication that you are not doing after the DEB? IVUS.
So as you are, you are not doing further pre-dilatation, to be honest. You are using this balloon as a delivery tool to deliver the drug. So whatever IVUS result, it will stay. Then it is not needed to go ahead because you are not sure whether you are doing some further, injury to the vessel wall, and it is probably not indicated.
I always tell whosoever is scrubbing with me that IVUS, ROTA, anything is for you. We are not for IVUS or OCT. It is not like if you have taken IVUS, you have to go with pre, post, 3 times, 4 times. Absolutely not. So when we do normal stenting, we usually do post stenting. You see the stent optimization. Like in drug-coated balloon, if you get a 3 mm vessel, clearly less than 10% residual stenosis, TB3 flow, no dissection visible, just leave it there. This is the living criteria for DCBs. There's no point in going and prolonging your, using IVUS again and again.
Yeah, I mean to say in bifurcation lesions, as Rijit also told, I had this question. In bifurcation, post-dilatation is must, they have shown. So post-dilatation after DEB for bifurcation lesion, for example, provisional stenting, or you're taking dedicated. They have told final kissing is a must. It gives a better result.
We can keep on debating regarding the role of final kissing. You know, very recent data emerged where it is, you know, showing there is no head-to-head advantage of doing final kissing. So we can keep on doing, because these are very early data. We are not very sure whatever we are doing or you are doing, who is right. Only future will give us the proper answer.
Yeah. Just a last question. De novo DEB, how long you are continuing DAPT?
If there is no high bleeding risk, my protocol is similar to drug-eluting stent.
We have a separate lecture.
By which is high bleeding risk, we can shorten it.
Okay. Moving on to the third case, Dr. Arijit Ghosh.
Arijit, you was there, na? Yeah.
So respected chairpersons, thank you Dilip for giving me this opportunity. So I will be discussing two cases. I have been using drug-coated balloon for quite a while from now. So I have picked up two such cases from my collections. So the first is a DEB instant restenosis, which happens to be one of the strongest indication for the usage of DEB. So this is the story of a 39 years old female, diabetic for 6 years. She came to me during the COVID days with an unstable angina, and PTCA to the LAD and LCX was done. But in 2023, she again landed up with a high-grade angina. So this was what the check angio revealed. This was LCX instant diffuse instant restenosis. The LAD stent was patent, and from the previous records, I found that the LCX stent was 2.75 into 40, and the post dilatation was completed with a 3 into 15 millimeter at 18 atmospheric pressure. So this is the indication for usage of drug-coated balloon according to the 2018 ESC guidelines, which says that drug-coated balloon is a class 1 indication for usage in ISR. So as usual, the ISR segment was crossed with a regular wire with the support of a 1.2 into 8 millimeter balloon, and a serial pre-dilatation was performed with a 2.5 into 8 and 3 into 12 millimeter NC balloon. So these are the results after the pre-dilatation. So this was the IVUS run after the pre-dilatation were done. The IVUS summary is that the distal LCX was 3.25 millimeter in diameter. The diffuse neointimal proliferation was there in the diffuse ISR as usual, and the proximal LCX had a diameter of 3.5 millimeter with a heavily fibrotic plaque burden. A Wolverine balloon was used distally according to the diameter which was revealed by the IVUS run, and a 3.25 millimeter, 3.25 into 10 millimeter Wolverine balloon was used to cut the plaque. And the proximal segment was modified further with a 3.5 into 12 millimeter balloon at 12 atmospheric pressure. So even after putting our best foot forward and the gadgets available in my lab, I had found a lot of residual plaque burden at the LCX ostium. And here I was very confused whether I should be putting in the second stent or I should be doing a drug-coated balloon. But still then, I thought of going with the initial plan to put a 3.5 into 30 millimeter sirolimus coated balloon at the proximal LCX, and the distal LCX being meant by a 3 into 30 millimeter sirolimus coated balloon. So this was what was done, and this is the final result. So like Dr. Khan's case, there is a residual plaque burden at the LCX ostium despite all of my efforts. So the importance of IVUS, the IVUS helped in identifying the mechanism of ISR as usual, and it was an under-expanded stent with neointimal proliferation, adequate plaque modification with the 1:1 pre-dilatation was done, and proper sizing of the DCB according to the IVUS. So still now the deadliest meta-analysis, we find that the primary efficacy endpoint, that the target facility vascularization, is still better with the drug-coated stents. but the primary efficacy endpoint, safety endpoints are almost similar as compared when we compare a drug-coated stent with a drug-coated balloon. So moving forward to my next case, this was a primary angioplasty done at the mid of night. This was a occluded LCX from the ostium, occluded LED from the ostium. Primary angioplasty was done with a 2.75 millimeter, 2.75 into 24 millimeter DES, and this was a diffusely diseased LED. Post-dilatation was done as usual, and this was when I left the patient during the primary angioplasty. So I brought the patient a couple of months back with a plan that I will be mending the distal LED with 2 drug-coated balloons. So a pre-dilatation with a 2.5 into 15 millimeter balloon was done, and this was the pre-dilatation. I was afraid of further pre-dilating because I had a dissection in the distal part of the LED as well as in the proximal part of the LED. So I decided to put the drug-coated balloons, and the distal was meant with a 2.5 into 25 millimeter balloon, and the proximal with a 3 into 30 millimeter balloon. There was a dissection in the mid part of the LED as you are all seeing, but as it was not flow limiting and there was no persistent dye staining of the vessel wall, I decided to leave the artery. I waited for 10 minutes on table as I was apprehending an acute vessel closure. So as all mentioned that type B dissection can be left behind, type C and type D onwards, type C onwards vessel dissection are really life-threatening, and in that situation we might require a drug-coated stent. So these are my 2 cases.
Very good presentation. And I think small dissections, as you have rightly done, they can be left, they will heal on them onset. Okay.
It looked like a spiral dissection, and in this condition you never know how the patient will behave, and it looks like TIMI3 flow now. So it's better that you waited 10 minutes and then you took a call.
No, I have waited 10 minutes.
And after removing the wire, you should wait.
It was almost 15 minutes.
There,
I was really afraid with this type of dissection.
So
I waited for 15 minutes.
Yeah, it looked like in the kind of vessel contour outside, you see some staining, some dissection, it's all right. But it looked like a nasty kind of spiral dissection. So I would have taken out the wire, waited for 15-20 minutes, at least.
That I did. That I did.
And then.
Acha, like after the deploying of stent in case, after DEB, if you would have done an IVUS and then you would have seen a dissection there, so what would have been the next, even if it is not there in the angiographic view, that is the idea, I think, to do an IVUS post
look,
Hema,
you should be deciding upfront whether you will be using a drug-eluting stent or a drug-coated balloon. So intravascular imaging should be done after you have modified the plug. And there are some studies which show that in an OCT, if you find a dissection which is extending into the media, you can think twice before going for a drug-coated balloon. In that situation, you might use a drug-eluting stent. So I find that after the plug modification, it makes sense that you use an intravascular imaging, but after you have done a DEB, there is no proper reason to go for an intravascular imaging.
Okay. Nice presentation, Dr. Arijit.
Thank you.
Dr. Somo Patro, I think he's not here. Okay, then Dr. Dhananjay Kumar.
Good evening, respected chairpersons, dear audience. I am presenting 2 cases of calcified coronary artery which I have treated with DEB. So this was the first female of 78 years, presented with anastomy with ongoing angina. She was diabetic hypertensive, her ejection fraction was 38% and she was on pacemaker. So her culprit was this LCX, tortuous, acute bend, as well as severely calcified and critically stenosed. So I decided to go upfront with rotablation first. Did rotablation, somehow videos are not running. Rotablation and then pre-dilatation, sequential pre-dilatation followed by cutting balloon and sorry, this is again not running. Then did the IVUS, the proximal segment was of 3 mm, the distal one was 2.25 and the smallest lumen was around 2.25, at the bend it was around 2.5. So I decided to give 2 days a DEB in the distal part, 2.5 40 sirolimus eluting balloon, and in the proximal segment it is 3 into 25 again sirolimus eluting balloon, and somehow videos are not running. Okay, so this was another case. This is the final result of first case. This is the final result of the first case. Yeah. This is the second case. Again, 77-year male with class 3 angina. He was hypertensive. His ejection fraction was 45%, and this time the culprit vessel was RCA, critically stenosed and diffusely calcified. Again, upfront rota, sequential pre-dilatation. This was, I was hoping to gain a good luminal gain after cutting balloon, but I could not achieve that. So I finally gave drug-eluting balloon 3.5 into 40 sirolimus, and this was the final outcome. So I am routinely using DEB. In last 4 years, I have used more than 150 DEB, and in more than 40% of the major vessels, and at least more than 80% in de novo lesions. So I have stopped doing bifurcation stenting. Initially, like every interventional cardiologist, I was enthusiastic about the bifurcation, but I have stopped doing this. I am using now this combination of DES and DEB. And in diffusely diseased or in calcified lesions where we have not gained the proper luminal gain, partially yielded segment, I used to give either DEB alone or DEB plus DES. I am never using a high pressure DEB. Like whenever I am deploying the DEB, I am deploying at the nominal pressure only. I have never crossed that. Sometimes if I am using a long segment DEB and the distal and the proximal diameter is, there is discrepancy between the proximal and distal diameter, and I have to achieve some diameter in the proximal segment. Sometimes I have to go beyond that, but usually I avoid that. I am using cutting balloon in majority of the cases, and I have done 5 STEMI cases with DEB. No flow limiting dissection are very common, as you all said, but I have accepted many of them. Less than 10% was major dissection requiring days after giving DEB. So one patient came within 1 month. I have used, the lesion was diffuse LCX, it was large LCX but diffuse ostium to distal, and I gave 2 DEB of 40 mm, both the DEB was sirolimus, it was magic touch, and within 1 month the patient came with chest pain. I did the angiogram and the whole vessel was diffusely again diseased, like similar to the previous one, and I didn't have another option. I gave a stent thereafter, and otherwise in all the 150 patients, in 1 patient I have used 4 DEB in 1 patient in different vessels. So I have checked at least in 25% of cases this QFR, and this has gave satisfactory result. So I am hopeful with this drug-eluting balloon. Thank you so much.
A nice presentation. I saw that you are using DEB in calcified lesions. So what are the long-term results? Are you?
Sir, I don't have any personal data, or but definitely I have learned from the data from the others. Like if you are using a stent in severely calcified segment where you are not going to gain a great luminal gain after giving a stent, your outcome will be definitely poor. So giving DEB will definitely give some hope to that segment.
Your case, you have done ROTA, you have used high pressure non-compliant balloon.
Sir.
So luminal gain was achieved. After that, you used DEB.
No, sir. In both the cases, luminal gain was not there. Adequate luminal gain. In the first case, it was at the bend. It was around 2 to 2.5 mm of diameter. At the narrowest part was hardly 2.25. So it was not. Even in second, the one segment was still under inflated, under dilated. So I avoided to use.
There
I
are
think
non-randomized
the point,
data. Non-randomized data are there for calcified lesions.
Uh-huh.
So in calcified lesions, your DES results are also not that good.
So that is the point.
So
that's a good point we have mentioned
DCS is
about
comparable.
calcium. But I think rather than your point is well taken regarding calcified lesions, whether you're expecting stent expansion or not, you can use DEB. But you're using in proximal vessels, and you've done in so many cases. So what has been your experience in proximal large diameter vessels?
Sir, till now, except one case, no one has come up with chest pain, or like I have done re-angio for at least 5 to 10 cases of DES in a short span of 4 to 5 years, but I have done only one re-angio for DEB case. So this is my experience.
Okay, Dr. Dhananjay Kumar, nice presentations.
One question.
So we move on to the next case, Dr. Subhashish Roy Chaudhary.
Okay, so this is going to be a very short, just one small case. We kept on discussing the indications of DCB this evening, and this case will show you a little bit different angle to the whole thing. So this was a 55-year-old male diabetic, a COPD, and it's a triple vessel disease. These are the angios for you, and you'll appreciate that this would be a very good case for a CABG. There's a bifurcation lesion of LADD1. There is a LCX which is distally diseased, and look at the OMs, they also have disease. Look at the RCA, it also has got a disease in the proximal and mid part. The problem was the COPD, for which he was a surgical turn down, and it's at that point of time that we sort of started discussing angioplasty for this patient. We wanted to reduce the metal burden. So what we did was provisional stenting of the LAD. We decided to just stent the LAD. I'll show the result that we got. Okay, so we accepted that flowing diagonal because we knew that we had many more things to tackle in this patient. We were much more interested in the circumflex. So what we planned for the circumflex was drug-coated balloons for the OM1 and OM2, and a stent for the LCX, which would go over the OM, second OM. Again, so that would bring in the issue of doing a bifurcation of that LCX OM. So this is what was actually planned. We were very certain that we will not do two bifurcations. That would make it more cumbersome. So first run of the IVUS in the OM2, and very startlingly that revealed a vessel of 3 to 3.5. So I'll come back to the angio. If I can play the angio for you. Okay. So this OM2, though it looks from an angio of about a 2.75 to 3 vessel, but on an IVUS, we saw it's about 3 to 3.5. So that's one thing that we would like to stress, that if possible, we do IVUS in every DCB case so that we are able to size our DCBs correctly. And it had a fibrotic disease that the osteum and osteums are supposed to have. So we did the predilation, aggressive predilation with the 3.5 balloon of the OM2, and then deployed our DCB, 25 millimeter sirolimus, going across the OM2 ostium. So we did not plan to first put in the stent and go across it, which is one of the strategies. This we felt was easier. After this, I'll just show you the result. Okay, so this is the result after the DCB has been put. After this, the stent was put across the OM2, taking care that we do not cross the OM1 ostium. And this is how it looked at the end, if you look at this image, right? And then we proceeded to the OM1, and startlingly, this OM1, even it was not so very evident on the angiography, had a fibrotic lesion in the tightest part, which was not opening despite high pressure balloon dilatation. So we went with the Wolverine, and after a lot of effort, did this open up a bit. So we were happy with this, and then we deployed our second DCB at the OM1, again covering the OM1 ostium. And this is what we had at the end. So the purpose of showing you this is that using DCBs can help you to reduce metal burdens, especially when we are trying to do almost a CABG alternative. And the second thing is, even if you don't have a picture perfect result, like let's say this OM2, we should be accepting 30% angiographic loss. Thank you.
Thank you. I think wonderful, selection of cases we saw. There's only one thing, one comment. You, all the procedure were done in only one view, RO caudal. There's a dominant circumflex. But
I've not shown the other views.
Okay.
It's a long case.
I think we conclude this session. It was a wonderful,
Okay, thank you.
Number of cases. So I thank all the chairperson moderators. Please, I request everyone to please stay back for 15-20 minutes. There are two very important presentations coming up. One is on DAPT, the antiplatelet therapy after DEB, and then second is adjunctive devices like rota and atherectomy devices, and then what are the results. So may I invite the chairpersons, may I request Panja sir to, and Dr. Kajal Ganguly sir to chair the session. 15-20 minutes, sir. Please, sir. And may I request the speaker, Dr. Subra Banerjee, to start the presentation.
So good. Sorry.
So Dr. Subra Banerjee will be talking on antiplatelet regime in DEB. That is important.
So good evening. I'm going to talk on the antiplatelet regimen in drug-eluting balloon angioplasty. And I promise not to keep you hungry for long. But coming to the basic, why do we need antiplatelet therapy after putting in a stent? Well, we all know it's to reduce stent thrombosis, and also indirectly and partially to reduce restenosis, and of course to reduce MACE. But what about DCB or DEB angioplasty? It leaves no metal behind, but still it does cause some intimal or plaque rupture, which normally settles in a few days. So at least theoretically, we can say a few weeks of antiplatelet therapy following a DEB angioplasty should be sufficient. However, this is not true in all cases, because the duration of antiplatelet therapy post DCB angioplasty depends on the clinical context, but whether it's a stable or acute coronary syndrome, the type of the lesion, de novo, ISR, bifurcation, etc., and also on the bleeding and ischemic risk. So the duration of DAPT treatment may need to be individualized. Now the optimal duration of DAPT after DCB is still unknown, as until recently there was no randomized controlled trial on the subject. Therefore the DAPT duration is mainly an expert consensus rather than being based on robust evidence. Now, the consensus is also evolving, and we have a lot of consensus, different consensus. We have the German consensus group, the Italian position group, Asia Pacific consensus group, and also AC update and the ACC guidelines. Now, the indications for DEB, as you know, like the classical indications have been in-stent restenosis, and the de novo small vessel disease, to which you can add bifurcation lesions as well. And there are also emerging and off-label indications such as de novo lesions in large vessels, acute coronary syndrome, those with high bleeding risk, and you can add diffuse lesions and calcified lesions to these. Now, let's see one by one. What about DAPT duration in ISR? Again, we do not have any randomized trial which have specifically looked into the duration of DAPT following ISR. And there's no head-to-head comparison as well with different regimen. But if you looked at the different studies have been done on ISR and the duration of DAPT that was given in those, that was used in those studies, then you would find it ranges from 3 months to 12 months. But again, so if the German the consensus group actually suggested that in case of DES, restenosis, the duration of dual antiplatelet therapy should be at least 4 months or for the duration of the previous drug-eluting stent, whichever is longer. But then, since most of the studies actually have used 6 months of dual antiplatelet therapy, the 2017 ESC focus update says, like for DAB, at least 6 months should be considered. Now coming to the de novo coronary lesions, again, the PEPCAD-1 SVD study, which was done, again, it was not a dedicated study, but in that study was done in de novo small vessels, and DEB was used for 1 month. And the German consensus group and the ESC guidelines of 2018, they both agree that for standalone DEB, that is where you have not used stent, DAPT should be given for at least 4 weeks. But if you use a stent either before or after the DCB, then of course the DAPT duration would be prolonged to 6 to 12 months. And this retrospective, and there's a retrospective real-world study, which is a single center analysis in a high-volume tertiary PCI center, which confirms that a 1 month duration of DAPT is quite safe after elective DCB-only angioplasty. Now coming to the bifurcation lesions, again, the different studies and registry, they actually used 3 months of DAPT. But when, the German consensus group have said like the DAPT for 4 weeks could be used if DCBs it's been done without putting in stent. But of course, if the stents are put in, then it has to be for 6 to 12 months. Now, what about high bleeding risk patients? And this has been discussed previously today. But if you look at the DEBUT trial, in that case, the DAB duration was shortened to 1 month, followed by lifelong single antiplatelet therapy, and this was shown to be non-inferior to standard DAPT regimen. Now coming to acute coronary syndrome, again, DAPT is generally recommended for 12 months, and this has been proposed by the Asia Pacific Consensus Group, and also is more or less recommended by the other consensus groups as well. Now, only recently, that's in the EuroPCR, in the recent EuroPCR, this REC cage-free 2 study was published, was not published, I would say was presented, which actually showed that in patients with acute coronary syndrome, if you're treating with drug-eluting balloon, then a strategy of DAPT including ticagrelor for 1 month, followed by ticagrelor monotherapy for 5 months, and followed by aspirin monotherapy versus, this strategy was found to be non-inferior to a 12 months standard DAPT therapy in such patients. So, of course, this would be very useful in patients who are at high bleeding risk, because you may go ahead with a DAPT duration which would be just for a month. Now, this has been proposed by Zhang that regarding, this is their recommendation, which says like in patient, if you have acute coronary syndrome, then you give it for 12 months. If it's patients with high bleeding risk, then you can give for a month, but in some cases, you may go to 3 to 6 months if the patient tolerates. In patients who have stable coronary artery disease, And in that case, for de novo or for large vessels, 1 to 3 months of DAPT should be fine. And in ISR, you go for 3 months, or in some cases for 3 to 12 months. Now, what about SAPT? I think Aftab probably showed a case where he did mention about just using SAPT. So is there any evidence for it? Now, what we find is there's a single center experience which shows that you can use SAPT, the efficacy and safety were similar. And if you note that in such cases, about 60-70% cases, aspirin was used. Now, this is my last slide. So being a bit intrigued and also confused with recommendation from various groups, I thought of taking help of AI, and I asked ChatGPT what should be the best approach. And what it said is for de novo lesion, 1 month of DAPT. You can extend it to 3 to 6 months if the patient is at high risk. For ISR, usually 6 months should be fine. For ACS patients, 12 months of DAPT should be given. And for high bleeding risk patient, you can reduce it to 1 month. Thank you.
Question particularly role of DCB, definitely you rightly point out acute coronary syndrome, it will be 6 to 12 months depending on the situations. If it is multiple vessel, definitely it will be 12 months, otherwise 6 months also acceptable. Chronic coronary syndrome, that case is a DC at 31st August 2024. They mention if there is no bleeding and if there is ischemic burden also moderate to normal, that case is 1 month to 3 months is sufficient. So that is well acceptable. And rightly point out in the case of DCB, definitely presence of acute myocardial infarction, there also acute coronary syndrome, DCB is coming out. In that cases, we better to use even with the single antiplatelet therapy at 6 months, yeah, it is quite sufficient. Any comment from anyone? Okay, Ghosh.
Yeah, absolutely. I actually showed what the study showed. And that is why I pointed it out that in that study, 70% patients were actually given only aspirin. Still, the results were quite good. So, but as you have said, like, if you look at the cage-free study, well, I would say, like, if you're using one, I think clopidogrel would be fine. Yes. I would stick to that.
Yes, chronic coronary syndrome guideline 31st 2024, August. They mention in case post-CABG routinely, that is the aspirin 150, average 100 milligram. In cases, particularly chronic coronary syndrome, in that cases, you see 75 milligram aspirin to 100 milligram sufficient lifelong. But if you alternately you can use the clopidogrel. They mention the alternately you can use the clopidogrel, same efficacy. Because cost efficacy aspirin is low, that is why everybody guideline paper for the aspirin better.
So what caught my eye in this good presentation, obviously you present, is the use of ChatGPT. What I would want to know, such a fine table there. Actually, I think you've used ChatGPT. I mean, in next presentation, we should at least ask the ChatGPT to make a presentation and see. And then it would be a game changer. You will have just only the chairpersons and not the speaker, is it?
No. I think I just
can make PowerPoint presentation also.
No, this slide they made actually.
No, only slide, and that too they will not give you chart.
If you can ask, they would also give it. But I think. But the purpose of giving it is not to rely on that, but just to show like what ChatGPT can do nowadays.
Okay, thank you, Saurabh.
So, Dr. Sunandan Sikdar will talk on
can you have the
effective adjunctive therapy in DEB.
So, good evening. I am the last presenter and I would like to go as fast as possible so that you are not kept away from dinner. So, the topic is adjunctive therapy. and as we have gone through the evening, different types of therapy we have already seen. We know the DEB principle, but one thing I would like to point out is this: during the deflation of the balloon, what can take place? Can we have a pointer? Yeah. So when the balloon deflates, there are a number of things that can take place. This is the retraction force of the balloon. As a result, the coating and the adhesive that can attach to the arterial wall, or it may not attach, or it may come up with the balloon. So individual lesions are different types, and as a result, we can have different results with the same type of balloon, same type of DCB balloon. Also, the covering, like you can see the shellac covering, this is like a sphere. If you have a coating like a urea, it is like fine needles. So these things can also change the amount of drug that goes into the arterial wall. Shellac, which is given in a sphere, has the highest number of surface area. But if you have a urea coating, it can go into the arterial wall because it is like needle. So different balloons can therefore have different type of results. Even different lesions can also have different type of results, because they are made up of different amount of fat, different amount of fibrous tissue, or different amount of calcium. So this is how does a artery behave after you have put in a drug-eluting balloon compared to a drug-eluting stent. So after 1 month, there is a vasomotion that comes in. Till 1 month, just after 1 hour, there is no vasomotion. After 1 month, vasomotion comes in, and it is most prominent with the drug-eluting balloon. That's why we are actually using it. And as we all know, stents have a more amount of acute gain and more amount of late loss compared to drug balloons, which have less acute gain and less late loss. So why is bed preparation so important? One of the reasons the bed preparation is important is that there is sufficient, it creates sufficient luminal gain, and also it creates actually a nidus for getting the drug in. So angiographically inadequate lesion preparation can lead to target lesion failure or target vessel failure. So it enhances the drug penetration into the vessels and increases the anti-restenotic properties. So drug balloon required have deliverability, trackability, and crossability, and for this, bed preparation is a must, because unless you prepare the bed well, the drug will not go in, the drug may be lost in the process of going in, and so you will have less amount of restenosis. So how do the bed and the balloon interact? This is a very well-known paper from 2021 JAC. What I would like to highlight here is an important role of calcium. So if we have a calcium, the calcium is an inert substance. And as a result, unless you break this calcium, the drug will not go in, because calcium has no role, it cannot participate in the drug-bed interaction. So calcium is totally inert. What we do is put the drug into the fibrous tissue and put it in the media. So intima is inert, adventitia is also inert. Mainly it is the media that is the place where everything takes place. So we all know this, actually, this technique. And one of the important result of this paper is inflation time of DEB. So in this paper, which came out in 2018, the inflation time of DEB was around 60 seconds. So what is the impact of using a guide liner catheter? So this was a paper based on this guide liner, and it showed that guide extension improves the drug delivery because the balloon is not in contact with many surfaces to lose the drug. And if you use a guide liner, particularly for difficult lesion, the drug may go well inside in the lesion which you want to target it. So how do you size? And this is the most basic thing, that is the NC balloon and the cutting balloon. And how do you size it? You can use a 1:1 NC in high pressure, or you can use a cutting balloon at nominal pressure, or you use a undersized cutting balloon at high pressure. So this is a paper which showed that if you use a cutting balloon or a scoring balloon, the neointimal modification particularly leads to a good angiographic result. But many of the time, it will not lead to a good result in the long term. It will be same if you use a cutting balloon or a non-compliant balloon. The long-term result will be same. The acute angiographic result, if you use a cutting balloon, is better. But in the long term, the non-compliant balloon and the cutting balloon will be same. This is the paper which about the use of rota in these DCBs. Particular among this is a use of DCB in a case of Kawasaki's disease. They have used rota in a Kawasaki's disease with calcified artery and have used DCB there. This is a role of laser in the as an adjunctive therapy for the DCB. We have not used it, and I do not know about this, but there is literature about it. But however, there is only some acute angiographic result is good, as we have already discussed. The long-term result remains the same. So this was a paper about brachytherapy. We usually don't do it. A newer type of cutting balloon may be the offing, where we have microneedles with the drug. So that actually is a scoring plus cutting. This figure we have already seen in many presentations, so I will not elaborate. Now we'll go to a case where we used a cutting balloon, and the next case where we thought of using a cutting balloon, ultimately could not use it. So here is an unstable angina. Patient had already an LAD stent. Now we have a stenosis developing, probably because a plaque had shifted in the circumflex ostium, and now we have a circumflex ostium stenosis. We used pre-dilatation, prepared the bed, that is the basic thing. But what we did next was, we also did which we had discussed previously, we also did a kissing balloon, kept a balloon in the LAD, and because we did not want a plaque shift to the LAD, we did a kissing balloon after we have done a DEB. So the result was fine. So this patient has been done quite previously, and he is doing well. This was one of my colleagues' case which we have done together. Next patient is a patient who had a calcified LAD, which we do with an IVL with an IVAS guidance. And actually we had a 3.5 stent, which we post-dilated to 4. It was done in February. However, now we can see here, the result was quite good, and we didn't have any underdilatation at that time. On the angiographic view, we did an IVAS, it was not there. So now he presents with an unstable angina, and we can see the restenosis, focal restenosis of the stent. So this ISR we had thought initially of using a drug-eluting balloon. We pre-dilated it repeatedly, and this was the, I am coming to the, so OCT is very important, because OCT can differentiate between neoatherosclerosis and the neointimal hyperplasia, and this is the OCT run. If we come here, I think here you can see the, there was a basically neointimal hyperplasia which is going on very strongly. So we had initially when we were putting the non-compliant balloon, there was a lot of melon seedling, and we were not able to fix it at that place. So ultimately took a Wolverine, and after Wolverine there was a comparatively better result, went up to even higher pressures. So as we know, Wolverine has a 127 micron, very good atherotome, and we ultimately had a nice result after Wolverine. So we can see here. So we had a dissection there. So this dissection may be often left, that we all know, but another problem was that this was now a vessel of 4 mm dia. But the drug-eluting balloon that we had maximum was 3.5. So I had to settle with a stent because I didn't think that 3.5 will be giving drug to that place. So this is a place where we are stuck up, we couldn't go for a drug balloon. So this is one of the important table that came up in JAC. So I would like to highlight there are certain places where sirolimus DCB has been recommended. Particularly if you want to have a good transmission of the drug. And here you can see if there is a lipid core, they say that you use sirolimus DES. If there is a lipid core with only small amount of plaque, you use a DCB. But if you have a huge amount of calcium, they have preferred DES. So key takeaways are bed preparation is crucial. Most commonly we do it with a cutting balloon and a NC. Though rota, IVL, laser, brachytherapy are there. Guide extension catheters may allow for drug preservation, and imaging is very important, particularly with OCT. Thank you.
Thank you, very extensive lectures, and your final talk, definitely adjunctive therapy, particular different device to be used. But important, particularly common calcium, moderate size calcium or mild calcium, in that cases, you have to use the even bulbarine or this cutting balloon, anything. So undersized to be used, just prevent the dissection. That is very one message from the Anthony Colombo. He is already published there. Thank you very much indeed for your present hearing.
Thank you. Thank you. Thank you, sir. And we conclude our program here, and thanks to everyone for coming and making this DEB Conclave, the first dedicated DEB Conclave of India, grand success. Thank you everyone. Thank you.